Hello. அனைவருக்கும் வணக்கம். இந்த இனிய வேளையில் உங்கள் அனைவரையும் வரவேற்பதில் மற்றற்ற மகிழ்ச்சி. கெம்கோ முன்னாள் மாணவர்கள் அமைப்பு மற்றும் செங்கல்பட்டு அரசு மருத்துவக் கல்லூரியின் பொது மருத்துவத்துறை இணைந்து நிகழ்த்தும் இன்சுலின் சிகிச்சையில் புதிய முன்னேற்றம், புதிய தகவல்கள் என்ற இந்த அறிவுசார் விழாவிற்கு உங்களை வருக வருக என வரவேற்கிறோம். பலரின் கனவுகளை நிறைவேற்றும் தருவாயில் பணம் ஒரு தடையாக இருக்கும். அந்த தடையை உடைத்து மாணவர்களின் கல்வி கட்டணத்திற்கு என்றும் உறுதுணையாய் இருக்கும் எங்கள் கல்லூரியின் தூணாக விளங்கும் கெம்கோ முன்னாள் மாணவர்களை மனதார விழாவிற்கு வரவேற்கிறோம். இப்போது விழாவின் மேடைக்கு விழாவின் தூண்களாக இருக்கும் சான்றோர் பெருமக்களை அழைக்கிறோம். We now request Professor Dean Dr. G.R. Rajashri ma'am to get on the dais. We also welcome Dr. A. Anita ma'am to occupy the place on the dais. We also welcome Dr. P.K. Bhaskar sir, Medical Superintendent sir, to occupy the place on the dais. We also welcome Dr. P. Sridhar sir, Aramu sir, to occupy the place on the dais. We welcome Dr. Narmada Lakshmi ma'am to occupy the place on the dais. We also welcome Dr. S. Suresh sir, President, Chemco Alumni Trust, and Dr. A. Panneerselvam sir, Secretary, Chemco Alumni Trust, and Dr. K. P. Pichumani sir, Treasurer, Chemco Alumni Trust, and Dr. P. Kulothunga Soran sir, Secretary, Chemco Alumni Association, and Dr. S. Manoharan sir, President, Chemco Alumni Association, and Dr. S. Silangovan sir, and Dr. R. K. Shekhar sir to occupy the place on the dais. தமிழ் எங்கள் பேச்சு, தமிழ் எங்கள் மூச்சு, தமிழே எங்கள் சாட்சியும் நீ. தமிழ் எங்கள் பேச்சு, தமிழ் எங்கள் மூச்சு, தமிழே எங்கள் சாட்சியும் நீ, நீட்சியும் நீ. உலகின் தொன்மையையும் புதுமையையும் ஒருங்கே பெற்ற உயர்தனி செம்மொழி. தமிழ்த்தாயை தரணி முழுதும் மனதார போற்றுவோம், தமிழ் அணங்கை வணங்குவோம். தமிழ்த்தாய் வாழ்த்து பாட அனைவரையும் எழுந்து நிற்குமாறு அன்புடன் கேட்டுக்கொள்கிறோம். தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே, அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற, எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே, தமிழனங்கே உன் சீரிலமை திறம் வியந்து செயல் மறந்து வாழ்த்துதுமே, வாழ்த்துதுமே, வாழ்த்துதுமே. இப்போது பாரம்பரியமாக எங்கள் செங்கல்பட்டு மருத்துவக் கல்லூரியின் மாணவர் மனதில் ரிங்காரமிடும் கெம்கோ பாடல். இப்பாடல் இயற்றிய மருத்துவர் இளங்கோவன் அவர்கள் முன்னிலையில் ஒலிப்பதில் நாங்கள் பெருமிதம் கொள்கிறோம். கெம்கோ அலுமினி பாடல். இந்த வேளையில் நம் கெம்கோ குடும்பத்தில் நம்மை விட்டு பிரிந்து இறைவனடிச் சேர்ந்த டாக்டர் அப்துல் குத்தோஸ் சார் 1972 பேட்ச் மற்றும் டாக்டர் குமரவேலு சார் 1978 பேட்ச் அவர்களின் நினைவை நெஞ்சில் வைத்து எல்லாரும் எழுந்து நின்று அமைதியோடு அஞ்சலி செலுத்துவோம். நன்றி. விழாவில் கலந்து கொண்ட அனைவரையும் வரவேற்க வருகிறார் கெம்கோ அலுமினி ட்ரஸ்டின் தலைவர் மருத்துவர் சுரேஷ் அவர்கள்.
Good morning to all. Respected Professor Rajshri, Ma'am, Dean, Chengalpattu Medical College, Dr. P.K. Bhaskar, Medical Superintendent, Dr. Anita, Vice President. Yeah. Okay. Dr. Narmada, HOD of Medicine Department, who's organizing the CME today, and my colleagues and friends from our trust and association. It gives me great pleasure to extend a warm welcome to you on yet another CME program, which is conducted by the Chemco Alumni Trust and Association. I would extend a very special and warm welcome to Dr. Anil, who has come here. He's been our founder, he's been the architect of the association. Started in 1997, I remember him going from person to person, individual, motivating them to become members of this association. And in the year 2011, we formed a trust. Now we have 1,100 members, and the number is increasing every year. And the trust has been extremely active, helping college students and also academic CME activities. Also on the social front, annual get-togethers are happening where we have a session for meet and greet and catch up with our friends. And a very important thing that has happened in our association is that we have instituted a Chemco Alumni Trust annual endowment oration. And this has been done at the MGR Medical University. Normally, oration which is instituted at the university will be held at the university campus. But as a special permission, the MGR Medical University has allowed this endowment, annual endowment to happen in our college itself, which is extremely good. And our Vice Chancellor was very kind enough to help us do that. The first oration was given by Dr. Ilangovan, our senior cardiologist, and also the first batch student. So we feel very proud of that, and we are all looking forward to the next oration. I would today, as I said, having an academic program periodically helps not only in meeting each other and also trying to do something for the college and the enhancement of knowledge. I think it's also a primary responsibility of the seniors who are there to bring there's so much talent. Today, people who have passed out from here are all over the world and are absolute stalwarts in that field. I'm very proud to say that when somebody comes from the US and say, I'm a past pupil of Chengalpattu Medical College, it's always a matter of pride. So with this, I would once again invite you, welcome you to this gathering, and I hope you will be benefited by the excellent talks that we are going to listen very soon. Lastly, as students, I request you all to become members of the association. The more the number we are, the stronger we become, and we can contribute back to the college itself. How we can improve this college 15 years from now or 20 years from now, you should feel your own institution. When I come and visit here, see the amount of changes that are happening. So today I had the opportunity to visit the neurology department. They've got an absolutely state-of-the-art machine for doing transcranial Doppler. So this is a matter of great excitement, and to see that your college developing in the way it is and serving the community in the best manner possible. So the highest in technology available for the common man, and that's what the institution is all about. So I request you all to become members once again, and thank you for coming here today, and I wish the function all the very best. Thank you.
தேங்க்யூ சார். காரிருள் கரைகளை கதிரவன் கரைக்கும், நோயிருள் மழைகளை மருத்துவம் குறைக்கும், பேயிருள் அறைகளை அறிவியல் அகற்றும், பொய்யிருள் சிறைகளை அன்பு மட்டுமே அழிக்கும். எனவே மெய்ப்பொருளை விளக்க, உண்மை ஒளியை உலகிற்கு அளிக்க மாண்புமிகு உள்ளங்களை மேடையில் அழைக்கிறோம். குத்துவிளக்கு ஏற்றம்.
Start the function by lightening the kutuvilak.
தேங்க்யூ சார் அண்ட் மேம். தற்போது விழாவின் தலைமையுரையாற்ற செங்கல்பட்டு அரசு மருத்துவக் கல்லூரி மருத்துவமனையின் முதல்வர் பேராசிரியை மருத்துவர் ஜி.ஆர். ராஜஸ்ரீ அம்மா அவர்களை அன்போடு அழைக்கிறோம்.
It's a very proud morning today to be present amid learned and people who have really made a Chemco a grand success, especially Dr. Anal, who has started Chemco, founder of Chemco, Dr. Ilango, who made the theme song, and Dr. Pichumani, Selvam, Dr. Suresh, Dr. Purushottam is not here present, Kulotunga Churan, and Dr. Manoran, with whom I've worked in Arinirana Hospital for almost 5 years, Dr. Shekhar, and if I've left out anybody, I'm sorry. It's a wonderful morning, and I'm really feeling very proud to be here this morning among everybody here. Insulin is one thing which is widened up day by day, especially Novo Nordisk is coming up with something or other new. Novopen 1, 2, now it's moving on further. And you have the Exubra, the latest, the nasal insulin, which is also coming up, and also there's so much of drugs. I think this is the apt topic for the UGs and PGs who have assembled here today. We have got all stars and laureates from Chemco who will be enlightening you students, so make use of it. And I'm really overwhelmed. I don't know what to really say. Thank you all.
Nandri Amma. We now request Chemco Alumni Trust President Dr. Suresh sir to felicitate Dean ma'am. Thank you, sir. இப்போது டாக்டர் இளங்கோவன் ஐயா அவர்களை பேச அழைக்கிறோம்.
எனது இதயத்தின் துடிப்புகளான செம்கோவினர்களே அனைவருக்கும் முதலில் எனது வணக்கம். If I would have been known that the function can be conducted in Tamil, I would have been much more happy. No. I can express my feelings both in Tamil and in English. That is not a problem. So if you are agreeable to you, I can go ahead with my speech in Tamil also. It's all I leave to the opinion of the audience. இந்த விழாவின் தலைவர் நமது செங்கல்பட்டு மருத்துவக் கல்லூரியின் முதல்வர் பேராசிரியர் டாக்டர் ராஜஸ்ரீ அவர்களே, மருத்துவமனையின் துணை முதல்வர் டாக்டர் அனிதா அவர்களே, கல்லூரியின் கண்காணிப்பாளர் அவர்களே, உள்ளுறை மருத்துவர் அவர்களே, நமது செம்கோ அலுமினி ட்ரஸ்டின் தலைவர் டாக்டர் சுரேஷ், செயலர் டாக்டர் பன்னீர்செல்வம், பொருளாளர் டாக்டர் பிச்சுமணி, நமது செம்கோ மேனாள் மாணவர் சங்கத்தின் தலைவர் டாக்டர் மனோகரன், செயலர் டாக்டர் குலோத்துங்க சோழன் மற்றும் இந்த மருத்துவ கருத்தரங்காய்விலே கலந்து கொள்ள வந்துள்ள பேராசிரியர் பெருமக்களே, உதவி பேராசிரியர்களே, இன்றைய தினம் நாம் நடத்துகின்ற நிகழ்வானது நமது கல்லூரியிலே படித்து ஹவுஸ் சர்ஜன், தட் இஸ் கம்பல்சரி ரொட்டேட்டரி ரெசிடென்ஷியல் இன்டர்ன்ஷிப் என சொல்லப்படுகின்ற பயிற்சியை முடித்து ஃபுல் ஃப்ளட்ஜ் டாக்டர்ஸ், முழு மருத்துவர்களாக வெளியே செல்லக்கூடிய மருத்துவர்களுக்கு செம்கோ அலுமினி ட்ரஸ்டின் வாயிலாகவும் நமது மேனாள் மருத்துவர் மாணவர் சங்கத்தின் வாயிலாகவும் இந்த விழாவினை ஒரு மருத்துவ கருத்தரங்கின் வாயிலாகவும் அவர்களுக்கு நல்வாழ்த்துக்களை கூறும் விதமாகவும் இந்த விழாவினை நாம் இங்கே நடத்தி கொண்டிருக்கின்றோம். முதலில் நான் இந்த விழாவில் கலந்து கொள்ள எனக்கு வாய்ப்பினை அளித்த செம்கோ அலுமினி ட்ரஸ்ட் குழுவினருக்கும் நமது மேனாள் மாணவர் சங்கத்தின் அமைப்பினருக்கும் எனது நன்றியை கூறிக்கொண்டு எனது உரையை தொடர விழைகின்றேன். நண்பர்களே, சில தினங்களுக்கு முன்னர் டாக்டர் பன்னீர்செல்வம் அவர்கள் இந்த விழாவினை குறிப்பிட்டு தங்களது கல்லூரி நாட்களின் நினைவுகள் சிலவற்றை பகிர்ந்து கொள்ள முயலுமா என்று கேட்டார்கள். அதற்கு நான் சரி என்று ஒப்புதல் அளித்தேன். அதன் அடிப்படையில் நான் உங்கள் முன்னே வந்துள்ளேன். நண்பர்களே, எனது கல்லூரி நாட்களின் நினைவுகள் என்று கூறுவது என்றால் பல கூறுவதற்கு நிகழ்வுகள் உண்டு. ஆயின் நேரத்தின் அருமை கருதி இரண்டொரு கருத்துக்களை மற்றும் இங்கே உங்களுடன் பகிர்ந்து கொள்ள விரும்புகின்றேன். முதலாக நான் எனது கல்லூரி வாழ்க்கை, அதாவது 1965 நமது கல்லூரி ஆரம்பிக்கப்பட்ட காலத்தில் முதல் பிரிவின் மாணவராக நான் சேர்ந்த காலத்தில் 1967 ஆண்டு முதல் 2 பிரிவின் மாணவர்கள் மட்டும் தங்கியிருந்த நேரத்திலே நமது கல்லூரியின் விடுதியின் விழாவானது நடைபெற்றது. அக்காலகட்டத்தில் நாங்கள் எல்லாம் நமது ஃபர்ஸ்ட் ஹாஸ்டல், தற்போது பெண்கள் தங்கும் விடுதியாக இருக்கின்ற லேடிஸ் ஹாஸ்டலாக தற்போது இருக்கின்ற ஹாஸ்டலில் நாங்கள் எல்லாம் அந்த காலத்தில் தங்கி படித்து கொண்டிருந்தோம். அந்த ஹாஸ்டலில், அந்த மருத்துவ விடுதியில் எங்களது முதல் ஆண்டு மருத்துவ விடுதியின் மாணவர் விடுதியின் விழாவானது நடைபெற்றது. அந்த விழாவில் நடந்த ஒரு நிகழ்வினை நான் இப்போது உங்களுடன் பகிர்ந்து கொள்ளலாம் என்று எண்ணுகின்றேன். அந்த நிகழ்வினை நான் உங்களிடம் அந்த நிகழ்வினை நான் ஒரு கவிதையாக நான் தற்போது தயாரித்து கொண்டிருக்கும் நமது செம்கோ குறித்து தயாரித்து கொண்டிருக்கும் ஒரு கவிதை தொகுதியில் அந்த நிகழ்வினை பதிவு செய்வதற்காக கவிதையாக அதை எழுதியுள்ளேன். ஆனால் எனக்கு இங்கு அதை கவிதையை வாசிக்கலாமா அல்லது அந்த நிகழ்ச்சியை ஆங்கிலத்தில் சொல்லலாமா என்று எனக்கு புரியவில்லை. So in that case, if that is so, I would like to recite the poem which has communicated with the event what had happened in the year 1967 when I was an undergraduate student in our alma mater. I will go through the poem. Originally, I have planned in the other way, but things has happening as it comes. இந்திய இதய கழகத்தின் சென்னை பிரிவின் பேராசிரியர் டாக்டர் ரத்னவேலு சுப்பிரமணியம் MD MRCP அறக்கட்டளை சொற்பொழிவு 26/9/2009. இந்திய இதயக் கழகத்து சென்னை பிரிவினர் ஆர்வமுடன் டாக்டர் RS என்று அனைவருமே அன்பாய் அழைத்திடும் டாக்டர் ரத்தினவேலு சுப்பிரமணியம் எனும் மருத்துவ மேதையின் பெயரினிலே பொழிவொன்று பாசமுடன் நிறுவினரே. அந்த பொழிவெல்லாம் மருத்துவத் துறையினிலே மதிப்புறு வகையினில் பணிகள் பற்பல புரிந்தோருள் தக்கதொரு மருத்துவரை தெளிந்தறிந்து ஆண்டிற்கு ஒருவரென அறிவிப்பர் பொழிவினை அவரெல்லாம் சிறப்புடன் ஆற்றிடவே. அவ்வகையில் 26/9/2009 ஆண்டு என்னுடைய வயது அக்காலகட்டத்தில் 61. அவ்வகையில் 29ஆம் ஆண்டின் பொழிவிற்கு என்னை பேசிட அழைத்தாரே சென்னை பிரிவின் இந்திய இதயக் கழகத்தார். அவர்தம் அழைப்பிற்கு இசைந்து யான் பொழிவாற்ற விழா மேடையிலே நின்ற அவ்வேளை என் விழியோரத்து மெல்லியதாய் கண்ணீர் திவலைகள். அவ்வேளை என் விழியோரத்து மெல்லியதாய் கண்ணீர் திவலைகள். அவையோர்கள் யாதன அறியும் முன்னே தொடர்ந்ததுவே என் குரல் ஆங்கிலத்தில். Because it was a scientific meet, we are supposed to speak only in English. தொடர்ந்ததுவே என் குரல் ஆங்கிலத்தில் அவையோரை நோக்கி அன்புடையோரே அனைவருக்கும் வணக்கம். என் பொழிவினை யான் தொடரும் முன் பேராசான் டாக்டர் RS பெருமகனார் குறித்ததொரு செய்தியினை கூறாது செல்வது எனின் அது அறமற்ற செயலென்று. If I don't express the thing what has happened in the past, it would be, I'll be deleting from the morality. So I stated, பேராசான் டாக்டர் RS பெருமகனார் குறித்ததொரு செய்தியினை கூறாது செல்வதெனின் அது அறமற்ற செயலென்று என் அடிமனத்து அமிழ்ந்திருக்கும் மனசாட்சி சொல்வதனால் சில மணித்துளிகள் என் மனத்துளதை வார்த்தை வழி செப்பியபின் மருத்துவ பொலிவுதனை ஆற்றிடுவேன் என கூறி சொல்லலுற்றேன். செங்கையிலே இளங்கலை மருத்துவத்தை இனிதே படித்திடும் காலை வருடம் ஒருமுறை கொண்டாடும் மாணவர் விடுதியின் விழாவிற்கு 1967ஆம் ஆண்டு அக்காலகட்டத்தில் எனது வயது 19. செங்கையிலே இளங்கலை மருத்துவத்தை இனிதே படித்திடும் காலை வருடம் ஒருமுறை கொண்டாடும் மாணவர் விடுதியின் விழாவிற்கு விருந்தினராக வந்தவரே டாக்டர் RS என்னும் தமிழ்நாட்டு தலைமை மருத்துவராம். இதெல்லாம் பின்னாளில் அறிந்தோமன்றி அந்நாளில் அவர் குறித்த சிறப்பேதும் சிறிதுமே அறியாத பேதையராய் நாங்கள் எல்லாம். இதெல்லாம் பின்னாளில் அறிந்தோமன்றி அந்நாளில் அவர் குறித்த சிறப்பேதும் சிறிதுமே அறியாத பேதையராய் நாங்கள் எல்லாம் இதன்றி வேறெதுவும் சொல்வதற்கில்லை. விழா நிகழ்வின் அப்போது ஹாஸ்டல் டேல that is where it was conducted. I am just mentioning where that hostel day, what is the venue of the hostel day. விழா நிகழ்வின் மேடை மாணவர் விடுதியின் புற்பரப்பில் சரியாக 6 மணி அளவில் மேடைக்கு விருந்தினர் டாக்டர் RSஐ தக்கதொரு மாண்புடன் அழைத்து வந்தனரே எம் மருத்துவக் கல்லூரி முதல்வர் டாக்டர் ஆறுமுகமும் விடுதி காப்பாளர் டாக்டர் ஜெயவேலுவும். மேடையில் அவர்கள் அமர்ந்த சில மணித்துளிகளில் மாணவர்கள் சிலர் சிறு பிள்ளைகள் போல் தாம் செய்வதன் தன்மையெல்லாம் தவறென்று உணராது காகிதத் தாள்களை சிறு சிறு பந்துகளாய் சுருட்டியும் அதனன்றி காகிதத் தாள்களில் அம்புபோல் செய்தும் விழாவின் விருந்தினர் அமர்ந்திருந்த மேடை நோக்கி செலுத்தினரே சற்றுமே சிந்திக்காது. இதை பார்த்த மற்றைய மாணவர் யாமெல்லாம், including me, when some of our friends were doing it, after seeing that, we all thought it is a heroic act. Though it was an unruly act, at that period of time, we thought it was a heroic act. And இதை பார்த்த மற்றைய மாணவர் யாமெல்லாம் இதெல்லாம் வீரதீர செயல் என்று எண்ணி இவரோடு சேர்ந்தோமே இச்செயலில். எம்மின் இச்செயல் கண்டு விடுதியின் காப்பாளர் வேகமாக எம்மிடம் ஓடி வந்து விருந்தினர் மீது காகிதத் தாள்களை வீசுவது பண்பென்று என கூறியுமே காகித அம்புகள் தொடர்ந்து பறந்தனவே மேடை நோக்கி. அடுத்து வந்த அறிவிப்பு. சிறப்பு விருந்தினர் டாக்டர் ஆர்எஸ் அவர்களின் சொற்பொழிவு என அறிவித்த அடுத்த நொடியில், நண்பர்களே, இந்த நேரத்தில் டாக்டர் ஆர்எஸ் அவருடைய உருவத்தை பற்றி சற்று நான் சொல்ல விரும்புகின்றேன். டாக்டர் ஆர்எஸ் அவர்களின் சொற்பொழிவு என அறிவித்த அடுத்த நொடியில் நெடியோனாய் நெற்றியிலே நீரணிந்து அமைதியின் உருவமாய் அமர்ந்திருந்த டாக்டர் ஆர்எஸ் முகத்திலே கோபக் கனல் தெறிக்க சட்டென எழுந்து ஒளிவாங்கி கருவி முன் சிங்கக் குரலில் கர்ஜித்த ஆங்கில வார்த்தைகள் இவ் 5 மட்டுமே. அவர் சட்டென கோபக் கனல் தெறிக்க சட்டென எழுந்து ஒளிவாங்கி கருவி முன் சிங்க குரலில் கர்ஜித்த ஆங்கில வார்த்தைகள் இவ் 5 மட்டுமே. டாக்டரேட்ஸ் வித்தவுட் கேரக்டர் இஸ் நத்திங். டாக்டரேட்ஸ் வித்தவுட் கேரக்டர் இஸ் நத்திங். ஆம், ஒழுக்கமிலா மருத்துவர்கள் எதுவுமிலர் என்றமைந்த வார்த்தைகள் விழா அரங்கிலே சிம்ம குரலென ஒலித்ததும் அரங்கமே அதிர்ச்சி மிகு நிசப்தத்தில். நாங்களோ இடியொலி கேட்ட நாகம்போல் அரண்டு மிரண்டு அவரவர் இருக்கையில் அமைதியாய், மிக அமைதியாய் அவரது உரை தொடங்கி விழா நிறைவு அடையும் வரை. அன்றிரவு அந்நிகழ்வில் நானும் ஒருவன் என்ற குற்ற உணர்வு மனத்திலே ஆறாத வடுயென ஆகிவிட துயில் கொள்ள இயலாத தூக்கமின்றி கழிந்ததுவே. அன்று அவர் கூறிய வார்த்தைகள் இன்றும் என் அடிமனத்தில் ஈர மரத்தினில் இருத்திய ஈட்டி போல். அன்று அவர் கூறிய வார்த்தைகள் இன்றும் என் அடிமனத்தில் ஈர மரத்தினில் இருத்திய ஈட்டி போல். காலங்கள் கடந்தன. ஏனோ கடைசி வரை அப்பெருமகனை கண்டு பேசிட காலம் கைகூடி வரவில்லை. ஆயினும் அன்று அவர் வார்த்தை வழி போந்த மருத்துவர் வாழ்வியலின் தத்துவ வழியொற்றி ஓரளவு பயணித்தவனாய் இன்று உங்கள் முன் என கூறி இதய இரத்தநாள நோய்த்தாக்கம் உலக அளவினதோடும் மற்றும் இந்திய நோக்கிலும் என தலைப்பினிலே எம் பொலிவினை தக்கதாய் ஆற்றி அமர்ந்தேன். Friends, these are the incidents which has happened in the year 1967 while I was a second year student, and the words told by Professor R.S. was still lingering in my mind. So, the doctors without character is nothing is absolutely true, and that has really had an impact upon my life and which has changed my life to the maximum extent possible. And I think such things would have been eye-opener, and I am standing before you because of such great persons' suggestions, advices in appropriate time to us. And second, I am going to another important incident. Sir, I am not taking your time, sir. Can I? Yeah, just this is another important. This is nothing, and this is nothing pertaining to me. This is pertaining to one of our junior Chemcos. This is very, very. This is what they need as youngsters. Friends, now I move on to the second one. It is about continuing struggle of our Chemcoids of 2000 batch, Dr. B. Badri Narayanan. Probably some of you would have been heard about him, Dr. Badri Narayanan. It would be more apt to know from his own words. The following are the contents of the email letter that he wrote to me on 24/10/2022. I obtained his consent around his midnight of yesterday, that is 7/5/2023, so as to share this contents with you all. To quote, "Dear uncle, few lines about my life with muscular dystrophy. I was diagnosed with limb girdle muscular dystrophy 2B in the third year of medical school in the year 2003. He was our old student of our college. I was a fun-loving person with a good sense of humor. When I was diagnosed with MD, I knew I had a tough road ahead, but determined to not let my life become subordinary, but make it extraordinary. Realizing how my life would change because of this disease and the challenges I will face to practice medicine in India, I decided to relocate to the US in pursuit of stem cell research. I contacted scientists in the US who advised me to get into PhD in order to do muscular dystrophy research. However, my application was rejected by many PhD programs due to lack of research experience. Taking up a friend's suggestion, I applied for Master's Public Health program and received admission in Western Kentucky University. I graduated from the program in 2010 and also received the award as the Outstanding Student of Public Health. After my MPH, I was planning to do my PhD in biostatics, but God had other plans. Serendipitously, I happened to meet with the University of Louisville Molecular Genetics Program officials who referred me to the program director, leading to my admission to the program within a week of my meeting. During my PhD, I worked on cardiac stem cells, doing research while using a wheelchair for my mobility, doing research while using a wheelchair for my mobility and living alone in an apartment. It was a challenging but fulfilling experience. After completing my PhD, I have made 140 job applications before getting my current position, which was my 133rd job application. I was rejected for being overqualified because of my visa status and disability. Around this time, I lost my mother, my sole support because of cancer. My mother passed away in less than 2 months after my marriage, and since then, my wife has been my biggest support. Together, we were able to navigate the hardships both in our personal lives and financially until we got current position at MCEPHS University in 2015. Now we are leading a peaceful and happy life, remembering our parents and with the values they instill in us. To unquote, friends, what else could be more motivational than Dr. Badrinarayan's real life message? Friends, before concluding my speech, my only request to these young doctors, the passing out doctors of CRRIs, don't fall as a prey to mobocracy as I did in the year 1967 at my age of 19. But take Dr. Badrinarayan as a role model to face the challenges in life, which he is facing all along since from his 19 years of age. Finally, my children, the end point of success in human life is nothing but the peace and tranquility. You all would definitely achieve this by adhering religiously the following: be strong and up-to-date yourselves in your profession by acquiring the day-to-day advancement in your field, that is knowledge and skills. Be honest and be bold in your action. All good things will prevail upon you automatically. Thank you very much for your kind passion hearing.
அவையோர் சூழ இளையோர் கைத்தட்டி எங்கள் கல்லூரியின் முதல் பிரிவு மாணவர் முதற் விதையாய் விதைந்து ஆலம் மரபோல் தழைத்திருக்கும் எங்கள் வெற்றி ஜோதியை ஏற்றி வைத்து இன்றும் என்றும் எங்களை ஓட வைக்கும் பெருங்கவிஞராய் விளங்கும் மதிப்புமிகு மருத்துவர் இளங்கோவன் ஐயா அவர்களுக்கு மரியாதை செலுத்தும் விதமாக பொன்னாடை போர்த்தி பரிசு அளிக்க கெம்கோ மேனாள் மாணவர் சங்கத்தின் தலைவர் மருத்துவர் மனோகரன் ஐயாவை அன்புடன் அழைக்கிறோம். இப்போது மகிழ்ச்சி தெரிவிக்கும் உரையாற்ற டாக்டர் ஆர்.கே. சேகரையா அவர்களை அழைக்கிறோம்.
Good morning. I thank the trust members and the Alumni Association members for inviting me and honoring me. I don't know how much worth am I for this recognition. However, I have to accept that I want to respect their feelings. இப்போ இளங்கோ சார் பேசணும்னா என்ன பேசலாம் எடுபடாது. அவருக்கு எனக்கு சின்ன டிஃப்ரென்ஸில் பெரிய டிஃப்ரென்ஸ் சொல்லலாம். அவருக்கு தமிழும் தெரியும், இங்கிலீஷும் தெரியும். எனக்கு தமிழும் தெரியாது, இங்கிலீஷும் தெரியாது. அதுதான் வித்தியாசம். ஆன் த ஸ்டேஜ் பேசுறது பெபே, ஆஃப் த ஸ்டேஜ் ஜுஜுபி. ஓகே, இப்போ என்ன பேசலாம் பசங்க கேட்க போதில்லை, சும்மா வந்து ரூல் அது ஒரு என்ன ப்ரோட்டோக்கால் மாதிரி உட்காந்துட்டு இருக்காங்க. நான் புதுசாக எதுவும் அட்வைஸ் பண்ணவும் போகிறதில்ல, பிகாஸ் தே நோ பெட்டர் தென் மீ. ஸோ சொல்வது ஒன்றே ஒன்று தான், அதாவது வயசு ஏற அனுபவம் ஏற அறிவு வளர அந்தஸ்து வளர பணிவு வளரணும். அதான் ரொம்ப ரொம்ப இம்பார்ட்டண்ட். தட்ஸ் மோஸ்ட் இம்பார்ட்டன்ட் திங். ரெண்டாவது வந்து ஜஸ்ட் டூ கேரி ஹோம் மெசேஜஸ் ரொட்டீனாக சொல்கிறது தான். See, no need to praise others, don't talk ill of them. Okay, no need to help others, please don't do harm. These are the two best messages in it. Last but not least, I invite Dr. Hari Krishnan to the stage. Today is his birthday, so youngsters can wish him and elders can bless him.
We now request Dr. Kulottungan Soran sir, Chemco Alumni Association Secretary, to felicitate Dr. R.K. Sekhar sir. On behalf of Chemco Alumni Trust and Association, we request the President, Dr. Suresh sir, and Dr. Manohar sir to felicitate Dr. Narmada Lakshmi ma'am, HOD, Department of General Medicine, Chengalpattu Medical College Hospital. தற்போது செங்காந்தல் 2023 சிற்றேடு வெளியிட்டு பேச வருகிறார் மருத்துவர் மனோகரன் ஐயா அவர்களை அன்புடன் அழைக்கிறோம்.
அனைவருக்கும் வணக்கம். ஆண்டுதோறும் செங்கற்பட்டு மருத்துவக் கல்லூரி முன்னாள் மாணவர்கள் அமைப்பு ஒரு கூடுதலை நிகழ்த்துகிறது. சென்ற ஆண்டு 84ஆம் ஆண்டு அணியைச் சேர்ந்த டாக்டர் குலோத்துங்கன் தலைமையிலான அணியினர் கப்பலில் பயணம் மேற்கொள்ள ஒரு நல்ல சந்தர்ப்பத்தை அமைத்திருந்தார்கள். அதே போலவே இந்த ஆண்டு 87ஆம் ஆண்டு மாணவர்கள் இங்குள்ள மயக்க மருத்துவத்துறை தலைவர் டாக்டர் பத்மநாபன் அவர்கள் அணியைச் சார்ந்த முன்னாள் மாணவர்கள் செங்காந்தல் 2023 என்ற பெயரிலே ஆனைக்கட்டி, கோயம்புத்தூர் அருகில் உள்ள ஆனைக்கட்டி எஸ்ஆர் ஜங்கிள் ரிசார்ட் என்ற இடத்திலே இந்த ஆண்டு கூடுதலை நிகழ்த்த முயற்சிகள் மேற்கொண்டு வருகிறார்கள். அதற்கான பிராக்சர் செய்தி குறிப்புகளை வெளியிடுமாறு நமது முதல்வர் அவர்களை கேட்டுக்கொள்கிறேன்.
On behalf of 87 batch, heartiest welcome to all of you to make this is a grand success on behalf of 87 Chemco batch in the presence of all the senior guidance.
மேடம் உட்காந்துருக்கீங்க.
இப்பொழுது விழாவின் நன்றியுரையாற்ற மருத்துவர் மனோகரன் ஐயா அவர்களை அன்போடு அழைக்கிறோம்.
So now we have come to a conclusion as a form of vote of thanks. At the outset, I thank our Dean, Professor G.R. Rajastri Madam. I have worked with her for the 7 years between 2006 and 2012 at Government Arinjanna Memorial Cancer Hospital, Kanjipuram. She was a pillar to me and family friend to my wife. She actually resuscitated my daughter when she was born in 2007 at Joseph Kurian Nursing Home at Saidap, Chetpet, Chennai. So our family friendship is growing day by leaps and bounds. Thank you very much, Madam, for gracing this occasion. I thank Vice Principal and our Chemco 87 batch, who is the organizer of this Chengandal 2023 meet, Dr. Anita Madam. We also thank Dr. Bhaskar Sir, Medical Superintendent of this hospital, for gracing this occasion. I also thank Dr. Sridhar Sir, RMO of this hospital, for gracing this occasion. Not but the least, the platform is created by Professor Narmada Lakshmi Madam, who was my PhD colleague, and we worked together between 2003 and 6 at Chengalpattu as assistants. Now, Madam has created this platform under the auspices of Department of Medicine, has arranged a nice CME. Thank you very much, Madam, for arranging this. I will be failing in my duty if I don't thank the founder of this alumni, Dr. Annal Sir. We know how he toiled to form this association from 1989. When I was CRRI here, he sowed the seeds as Chengalpattu Medical College Old Students Association. Then it was renamed as Chengalpattu Medical College Alumni Association. Now it has grown up as a tree because of his untiring efforts. Thank you very much, sir, for your gracious present. And Dr. R.K. Shagar, sir, he saw to that every student who completes CRRI becomes member of the alumni. So he raised the fund and he was the backbone of the Alumni Association. Thank you very much, sir. At this juncture, I request all the house agents who are completing their course by this month or next month to become members of the Alumni Association. I also thank Alumni Trust President Suresh sir, Secretary Pannirselvam sir, Treasurer Pichimani sir, and Alumni Association Secretary Kulothangan sir, and our HOD Pathology Ravi sir, and other professors and assistant professors, and my beloved students for having present today and gracing this occasion. Thank you very much, one and all, if I have left anybody. Thank you. Thank you very much.
நன்றி ஐயா. தாயின் மணிக்கொடி பாரீர், அதை தாழ்ந்து பணிந்து புகழ்ந்திட வாரீர் என்ற பாரதியார் வரிகளை
Today we have welcomed the CRRIs who are going to finish their house agency into the alumni fold. Similarly, 1998 batch who are completing their 25 years, they are going to celebrate by organizing a CME in August 18th in our auditorium at our college. I request our Dean Madam to grant permission for the same. Thank you very much.
I wholeheartedly grant them permission to conduct this. Thank you. Thank you.
Thank you. Thank you very much.
நன்றி ஐயா. தாயின் மணிக்கொடி பாரீர், அதை தாழ்ந்து பணிந்து புகழ்ந்திட வாரீர் என்ற பாரதியாரின் வழிகளின் மனதினை நிமிர்த்தி நாட்டுப்பண் பாடுவோம் நாம் அனைவரும்.
जननायक जय हे भारत भाग्य विधाता, पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा, विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा, तव शुभ नामे जाहे तब शुभ आशीष मागे, दाहे तब जय गादा, जन गण मंगलदायक जय हे भारत भाग्य विधाता, जय हे जय हे जय हे जय 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 हे.
We now request the dignitaries on the dais to occupy the chair off the dais. Now moving on to scientific session, we now welcome our chairperson, Professor Dr. R. Narmadalakshmi Ma'am, HOD, Department of General Medicine, Chengalpattu Medical College Hospital. Over to you, ma'am.
Madam, first speaker. Call me. Now we go on to the scientific session. I call upon the first speaker, Dr. Panneerselvam sir, to kindly come and grace the occasion. And now we'll have the session. We have 3 speakers. First speaker, Dr. Panneerselvam. He'll start the program now.
Good afternoon to everybody. At the outset, we profusely thank our Dean, Medical Superintendent, RMO, and our beloved Vice Principal, and my senior colleague, and the first batch of Chengalpattu, Dr. Ilango. And he is continuously helping us from our Chengalpattu Medical College emblem. He only formed along with his friends, and Chemco Alumni Trust emblem also he only formed, and a lot of songs and theme song. And he is getting involved from the year 1965 to till this minute, and till his end. I think he will continue to help our college. So we are profusely overwhelmed and thankful to you, sir, because you are continuously encouraging the youngsters. And our Suresh sir, our president, and all our colleagues. So we have taken this CME with the help of our Novo Nordisk help. So this 100 years of insulin, because a lot of drugs are coming and going, but insulin is staying continuously. But there is no substitute for insulin. Insulin is the hormone which is metabolizing the glucose and giving us the energy. If it is glucose is excess, getting converted to glycogen, protein and fat, stored, and whenever we starve, it is getting released, and again insulin is metabolizing, giving us continuously energy. Otherwise, insulin is anabolic and anti-catabolic hormone. But of course, 100 years before, we didn't have insulin. People suffering from diabetes, especially type 1 diabetes, they were dying due to diabetic ketoacidosis. Now, for the past 100 years, what had happened to insulin, let us see. So this 75 years of insulin also we celebrated in the year of 97, Diabetic Association. I was secretary at that time. So 97 is getting correlated with our Alumni Association also. In 97, August 15th only, we have started our first alumni meet at Savera Hotel, 25 years before. So, so agenda of the topic, history of diabetes and insulin, animal insulin. To start with animal insulin only we are using from 1923 to, of course, 1992. Then subsequently human insulin, then analogs, then future insulins, and conclusion is the agenda of topic today. History of diabetes. In 1500, before the birth of Christ, diabetes first described in writing. Hindu healers wrote that flies and ants were attracted to urine of people with mysterious disease that caused intense thirst, enormous urine output, and wasting away of the body. That was the description for diabetes before the birth of Christ, 1500 years before. 250 years before the word diabetes first used, Apollonius of Memphis coined the name diabetes, meaning to go through or siphon. He understood that the disease drained more fluid than a person could consume. Gradually, Latin word honey mellitus was added to diabetes because it made the urine sweet. So these are all happened before the birth of Christ itself. So discovery of insulin, 1921, Frederick Banting is orthopedic surgeon, posted in the physiology department. Even now it is continuing. So other specialty people posted in the other concern, not in the concerned specialty. He was orthopedic surgeon, posted in the physiology department, and his assistant is Charles, postgraduate in the physiology, along with John MacLeod at University of Toronto. John MacLeod is the department head. Successfully lowered blood glucose of pancreatomized diabetic dog with injection of pancreatic extract from the healthy dog. So they only confirmed something is there to reduce the blood sugar during 1921. Insulin discovery, the people involved is Banting, Best, MacLeod, Colip is the biochemistry professor there in the Toronto University. So insulin timetable, 1921 through the present. 1921, this pancreatic extract was tried. Then insulin first used in the human being on 11/1/1922, almost 101 years over. Leonard Thompson in Government General Hospital, Toronto. Isoelectric point produced larger quantity of higher potency insulin in 23. In 25, first international insulin unit defined. 26, crystallized amorphous insulin added to insulin stability. Then 36, addition of zinc to protamine insulin, that is PZI. 39, globin insulin. Then NPH insulin 1950, neutral protamine hezidone. Hezidone is the scientist who discovered this protamine. What had happened? Protamine, so that this is called neutral protamine hezidone. Then lenti insulin 1951. 1955, structure of insulin delineated. Then radioimmunoassay of insulin becomes available. Pro-insulin discovered. Before insulin, pro-insulin, pre-pro-insulin. Then first pancreatic transplant happened in 1967. Insulin receptor defined in 71. U100 insulin got introduced. Then small dose intravenous insulin treatment for acidosis. Earlier they were giving large dose. Then small dose got introduced. Then C-peptide became clinical tool. Insulin gene cloned, purified single peak pork insulin got introduced in 78, open loop insulin delivery system. So 81, insulin receptor kinase, recombinant human insulin becomes available. After the recombinant only, we are not depending upon the animal. Earlier we were depending upon the animal. A lot of animals have been killed to procure the insulin from the pancreas. After recombinant technology, we are in a better position to produce large amount of insulin. First islet cell transplant happened in 89. Insulin pen delivery devices become available in 1990. Short-acting insulin analog got introduced in 96. So our Edmonton protocol for islet cell transplant introduced in 2000. Long-acting insulin analog like your Glargine got introduced in 2001, 22 years before. So to put it in short, from 2000 long-acting insulin, then inhaler insulin, madam was telling. Then Degludec in 2013, 2014 Rizodac, recently Icodac. Icodac is weekly insulin that got introduced 2 years before. Otherwise, insulin has come across lot of changes, lot of development over this 1 century. 1922, the Leonard Thompson, on 11 January 2022, he was given first charity patient to give insulin. He developed abscess and became more acutely ill. However, his blood sugar had dropped enough to continue refine what was called iletin insulin. 6 weeks later, a refined extract caused his blood glucose to fall from 520 to 120 milligram in 24 hours. Leonard lived relatively healthy life for 13 years before dying of pneumonia. Otherwise, his age was 14 years at the time of giving insulin. Then he was living with diabetes with this extract for 13 years and died at the age of 27 due to pneumonia. The first Jocelyn patient to receive insulin was Elizabeth, first treated on August 7, 1922, the New England Deacon's Hospital in Boston. She had not been able to leave her apartment for 9 months, but after 6 weeks of insulin therapy, she could walk 4 miles daily and she lived at up to 25 years. During pre-insulin days, Dr. Jocelyn noted, I used to count the days of my diabetic children lived. This was the status before the introduction of insulin. Or Jocelyn is the father of diabetes. But he started his practice before insulin era itself. Prior to the use of insulin, most young patients with diabetes die shortly after diagnosis. That mortality was 100%. But of course, after introduction of insulin, the mortality is almost nil now. With the help of antibiotic and insulin therapy, the mortality is now almost nil. Why it is getting disconnected often? The Nobel Prize in the insulin therapy, 1923, Banting and MacLeod was given Nobel Prize for discovery of insulin. 1958, Frederick Sankar for chemistry of insulin, amino acid sequence of insulin. And 1964, Dorothy Hodgins, chemistry, 3D structure of insulin. And radiomanias of insulin, 1977 to Rosalind Yeo. And 1980, Walter Gilbert, chemistry, nucleotide sequencing of the genetic engineering. Otherwise, insulin is the only hormone which is getting 5 Nobel Prizes. No other hormone got 5 Nobel Prizes. Insulin is the only hormone got 5 Nobel Prizes. So animal insulin only we were using for long years. At the time of introduction of animal insulin during 1990, one of my medicine professor was chairing the session. He was telling me, no, we are using animal insulin for 50 years. We do not know what is new and newer insulin. Human insulin got introduced at that time. Now animal insulin also had gone out of market from the entire world. Human insulin also going away from the market. Now we are using analog. Why we are discarding animal insulin? Commercial production of animal insulin started in 1922. First bottle contained U10 only. 3 to 5 cc were injected at a time. Pain and abscess were common until purer U40 insulin became available. So evolution of insulin injections. So we had bottles like this. We had metal and glass syringes like this. And of course, now varieties of syringes, plastic syringes, disposable syringes, and pens are available, what we are now. Earlier, in 1920, first insulin short-acting acid-base, acid pH, only bolus regime. We had to give 4 or 5 times insulin at the time of introduction. Then 1940, long-acting insulin got introduced. After long-acting insulin, basal bolus regime was followed. Then 1961, first combination of actrapid neutral pH split mixed regime came in. Then from 1964, we started giving mixed-odd pre-mixed insulin. Of course, now the regime is getting changed. Now after the introduction of continuous glucose monitoring and your pump, the regimes are getting changed. Of course, this was the insulin while we were undergraduate using. Plain and lenti insulin. Now it is not at all available in the market. Bovine insulin or the animal insulin. Cow or ox have been killed. Their pancreas have been procured. And from the beta cells, they have synthesized insulin. They have to kill a lot of animals to save the many human beings earlier. Now it is not happening. So structure of human insulin or animal insulin. So the human insulin A chain and B chain, the difference between the human and porcine, bovine is, porcine is pig insulin, bovine is animal insulin, or cow insulin or ox insulin. For human chain, B30 309, A8 position 309, A10 position isoleucine. But in porcine, instead of 309, in B30 position alanine. But in A8 and A10, almost same for porcine, that is pig insulin. But bovine, all 3 positions are getting changed, alanine, and valine. So that only the bovine insulin caused antibody formation, immunogenicity, lipotrophy. So that only we are not adopting animal insulins. We have switched over to human insulin now. Of course, human insulin not from the human cadaver. Human insulin is being synthesized. The complications of animal insulin therapy, hypoglycemia, local allergy, lipotrophy, insulin edema. Even the other insulin also will cause hypoglycemia, but not to the level of animal insulin. So this is insulin atrophy because of plain and lenti insulin. If you inject persistently in one particular point, the subcutaneous fat will get lost. This is a hospital, Raipeta hospital patient, while I was there in 1990. Again, insulin atrophy. This is insulin hypertrophy, lipotrophy. This is also insulin hypertrophy around the umbilicus. So the limitations of animal insulin, that is bovine or porcine insulin, do not mimic basal or physiological insulin profile, slower onset of action, that is 30 to 45 minutes it will take. Late postprandial hypoglycemia, bovine and porcine insulin, occasional insulin allergy, lipotrophy because of lot of impurities like pre-proinsulin, proinsulin, etc., despite purification technology which was used. So this was the drawback of animal insulin. But we were using it for almost 50 years, 1923 to 1990. Then human insulin got introduced. Again, human insulin A chain and B chain. So monomer, this is in the monomer form, whereas animal insulin is hexamer form. Human insulin produced by genetic engineering technology from yeast or E. coli. Semi-synthetic from pig. So human insulin not from the human cadaver. Some of them are under the impression like procuring animal insulin from the animal pancreas. Human insulins are being procured by the human cadaver. It is not so. It is being synthesized from yeast or E. coli or from the pig. Pig insulin is getting converted into human insulin. That is, your porcine insulin is alanine. Alanine is replaced by the threonine. Once you replace the alanine by threonine, almost equal to your human insulin, that is your threonine, A8 also threonine, A10 also alanine. Sorry, isoleucine. So this I have to. The commercial production of human insulin through recombinant DNA technology, biosynthetic human insulin, the E. coli, insulin A chain is synthesized and B chain also synthesized from E. coli, air oxidation, genetically engineered by human insulin is formed. So limitations of again human insulin, lack of mealtime flexibility, inadequate PPG control, higher risk of hyperglycemia, and basal insulin also higher risk of hyperglycemia, difficult to titrate. So there are 5 drawbacks. And again, this insulin also have to be given half an hour before food. So the entire world has switched over to other insulin called analogs. So it will take half an hour. They are giving in the hexamer form. So that we are giving insulin half an hour before food. But whereas analog can be given just before food or even after food. That is the advantage of analogs. Analogs are in the monomer form. Even after food also you can take. For example, doctor profession, our food time is not being designed. So just before food you can have, or even after food also you can have analogs. They are in the monomer form. From animal insulin to human insulin to analog insulin we have come out. So analog insulin, same principle, A chain and B chain of amino acid. So for aspart is ultra short-acting insulin, actrapid is short-acting insulin, plain also short-acting insulin, whereas novorapid is ultra short-acting insulin. The changes are happening in the B28 position. In B28 position, instead of proline, the aspart is being inserted. And for homolog, Lilly product, Lispro, that is B28 and B29 are getting exchanged by lysine and proline. And this is insulin glulysin, Apidra, lies B3 and B29 position, the amino acids are getting changed. By slightly changing the amino acids in the insulin chain, A chain and B chain, they are modifying the action of insulin. So Dr. Samji P. Moses used to criticize. See, animal insulin, the amino acid sequence is not on par with the human insulin. So that only we have come away from animal insulin. Now they are human insulin is getting, human amino acid is getting, chain is getting modified. Otherwise, again we are going back to animal model. So we do not know what will happen in future. That was his prediction earlier. But fortunately, despite modifying this amino acid sequence, of course, we are using it for almost 25 years now. 96, the analog got introduced. More than 25 years, so far nothing had happened. No allergy, no antibody formations, etc. And this is about short-acting insulin, novorapid, glulysin, and Lispro. This is long-acting insulin, insulin detimer, levimer. Again, in B29, this mystic acid is getting attached. And this is Lantus, A21 and B31, B32. The amino acid sequence are getting modified. Long-acting Lantus, that is glargine. This is insulin degludec. And B30 position, they have attached this hexadecanol, by which these are all the insulin which are acting more than 12 hours. That is, NPH is acting up to 12 hours or to 16 hours. These insulins are acting up to 16 to 24 hours. 24 hours. So designer insulin, otherwise analogs. So according to the interest or according to taste you are designing something, cloth, etc. Designer insulin, this rapid acting insulin, not short acting, this is rapid acting insulin. Lispro, Eli Lilly company, Aspart, Novo Nordisk, Glulysin, Aventis. And your pre-mixed insulin, again, Novo Mix. Instead of Mixod, you can go for Novo Mix, Humalog Mix. And Rysudac is recently got introduced, co-formulation. And long-acting insulin, Glargine, Detimer, Degludec. Otherwise, the name of the insulin totally got changed. 50 years before, only plain and lenti insulin. Now, different types of insulins. Comparison of human insulin and analogs. Lispro, Aspart, these are all analogs. Initiation of action only 5 to 15 minutes, whereas human regular insulin, short-acting insulin, initiation of action is 30 to 60 minutes. NPH 1 to 2 hours, Glargine 30 to 60 minutes. So otherwise, analogs or initiation of action is much earlier. So pharmacokinetics of various insulins. Aspart is ultra short-acting insulin. Regular insulin is human insulin. NPH is intermediate-acting insulin. Your zinc insulin is ultra-lenti. Glargine is the flat action. There is no peak for long-acting insulin, Glargine. So this is ultra-fast acting, faster Aspart. They have further modified. Even after food, you can take this insulin Aspart, FIASP, called FIASP. Nicotinamide absorption modifier, vitamin B3 is added. L-arginine added for stability, naturally occurring amino acids. So this faster Aspart is current status available, 3 ml pre-filled syringes. Option to administer up to 20 minutes after starting the meal. See, option to administer after 20 minutes also you can administer. This is also available in the market. This is short-acting insulin from normal pancreas. This is fast-acting Aspart insulin. So newer combinations now. Dr. Sundar and myself is close friends. I'm happy to see him here. So newer combination, so far we have combined short-acting insulin with intermediate-acting insulin or ultra-short-acting insulin with long-acting insulin, Rysudac co-formulation. And this combination is GLP-1 and basal insulin combinations. This is insulin Degludec Aspart. This is Degludec is long-acting insulin, Aspart is short-acting insulin, and insulin Degludec liraglutide and insulin Glargine lexinotide. These two are GLP-1 co-formulation. Sorry. Insulin Degludec Aspart is like your Mixod, but Mixod will act up to 12 to 16 hours, whereas insulin Degludec Aspart, otherwise called Rysudac, will act for minimum 18 hours to maximum 24 hours. Rarely only patient may require 2 doses. Insulin Degludec, insulin Aspart is current status, 3 ml pre-filled syringes, and if you have refills also, we are using it for more than 5 years in clinical practice. And what can we expect then combining GLP-1 receptor analog and basal insulin? While you combine GLP-1 receptor analog with the basal insulin, there is reduction in the A1C, fasting and PP blood sugar, weight reduction also, hypoglycemia also very much less, and nausea also very much less. Insulin Degludec, liraglutide called IDEC Lira, current status and availability. This is also available, Giltophy is the name, but the effective control of diabetes plus weight reduction is there. Insulin Glargine and lexinotide, insulin Glargine plus lexinotide current status and availability. Formulation again, almost same principle, effective reduction of blood sugar as well as weight. You can use these combinations for slightly obese people which are not getting controlled by oral drugs. Newer insulins and their combination have got the hope of maintaining the HbA1c without much of hypoglycemia, weight gain, and with CV safety. Of course, now the delivery system also got changed, insulin delivery system. Now we have pen injectors and largely pump resolved the issue. This NovoPen 1, this got first introduced 60 years before. Then NovoPen 2 came, then NovoPen 3, NovoPen 4. Now we are in a position to NovoPen 6 and NovoPen Echo Plus. This is called Smart Pen. So Smart Pen, you can have attachment with your continuous glucose monitoring. and it assesses the glucose level at that time, accordingly design the insulin dose, ask you to give insulin. And it will store all the insulin dose, 2 days before, 5 days before, how much of insulin you have given in the morning, you have given in the afternoon, etc. This is called a smart pen. It has got link between the continuous glucose monitoring, it has a sensor-based glucose monitoring integration, and blood glucose integration, and continuous glucose integration. So because of electronic technology, these things are getting changed. Once upon a time, we were using metal needle and glass syringes, boiling the sterilizer. Now the technology is totally changed. One of our director of public health, while he was visiting PSC while I was in 84, one health inspector used to accompany him to boil the glass syringes with the help of spirit lamp. Same director of public health, while he was retiring, he was assistant director at that time. While he was retiring, he started using the insulin pen. And now the smart pen is going to come to the market. Already in the market in the USA. Smart pen calculates the dose, connected system with the continuous glucose monitoring, and Medtronic insulin pen, insulin dose calculator plus integrated system. You can integrate with your cell phone also. What dose you have given in the morning. Then you can integrate the cell phone with your continuous glucose monitoring. Now you have not taken your lunch, your blood sugar is 220. After your lunch, your blood sugar is predicted to go to 320. So your dose in the lunch, instead of 10 units as usual, you can go for 15 units. Like that, it predicts the dose and give. And of course, monitoring the blood sugar also, the sensor is getting attached to your cell phone. If you attach the sensor to the cell phone, you can get the blood sugar number in your cell phone. You can store it, you can transfer the number to your doctor or WhatsApp to your doctor. And this is continuous glucose monitoring. You can monitor your blood sugar with the help of your cell phone. So you don't require, whenever you want to check your blood sugar, each time you need not prick. 30, 40 years before, we have to go to the lab, give 2 cc of blood, then wait for half an hour to 1 hour, then get the report. Now through cell phone, if you want to see your blood sugar, immediately you can see your blood sugar with this continuous monitoring. Otherwise, your electronic systems are helping to this level nowadays. This boy is type 1 diabetic boy. His grandmother used to bring him 12 kilometers from Tirthani to take insulin. Then he was taught, even though he is illiterate, so that only my message for youngsters, whichever patient is taking insulin, kindly educate them. Simply giving the insulin, prescribing the insulin is one component. But see to that they learn the technique, they are taking the insulin. If they don't take the insulin, then no point in treating the patient. Again, they land up with either acute complication or chronic complication. Even though they are illiterate, they have been taught. This lady also illiterate, we have taught her how to take insulin with the help of pen. Sorry. So you can have it in the, and now insulin pump. So insulin is getting delivered through pump also now. Advantage, helps to achieve smooth control of diabetes, programmable in insulin delivery possible, but limiting factor is cost. Why pumps? Convenience, fewer needles, flexible lifestyle, skipping meals, exercise, eating out, erratic schedule, more precise dosing, improved control, less hypoglycemia, gastroparesis, dawn phenomena, exercise, automatic insulin delivery. Otherwise, the insulin pump is programmed to deliver 1 unit of insulin per hour for all the 24 hours. Just before breakfast, just before lunch, just before dinner, you can pre-program, or just before you go to food, you can program it also. 10 units extra before breakfast, 15 units extra before lunch, then 10 or 15 units extra for before dinner. Like that, you can pre-program also. Sometimes pre-program what is happening, if you delay your lunch and you have already ordered the pump to give insulin 10 units for lunch, if you delayed your lunch, it will give insulin at 1 o'clock. It will cause hypoglycemia. So that only now what designed, before your lunch, before your dinner, you can program and ask the pump to pump 10 units extra. So FDA has recently approved again first smartphone app for bolus insulin delivery. Again, everything is now getting linked to the cell phone now. The FDA has approved the first smartphone application capable of initiating insulin delivery for insulin pump wearers. According to a company press release, Tandem Diabetes Care has received clearance of offer a bolus insulin dosing feature as a part of its that is T-Connect mobile application. The app which connects the T-Slim X2 insulin pump will include a new feature giving user the ability program to cancel bolus insulin request through their smartphone. Through smartphone also you can control the pump. So this is otherwise called, for every meal our natural pancreas is secreting before breakfast, before lunch, before dinner. The basal level is there, the insulin secretion is there. We are supposed to treat the diabetic also with short-acting insulin before breakfast, before lunch, before dinner. But pump is clearing all these things. You can go for natural pancreas action with the help of pump. Future insulins, insulin Icodec is the recently approved weekly once insulin. So your glargine is daily once, this is weekly once. For 52 weeks for whole year, just 52 injection is sufficient. Again, the A chain, B chain, and the attachment of this C20 icosine fatty acid makes the insulin to work for 7 days. 7 days. Once weekly insulin Icodec demonstrated superior reduction in the A1C when compared to or versus insulin degludec in people with type 2 diabetes in onward to phase 3 trial. That is 28th April 2020, last year. This trial got over. But fortunately to tell you, the Novo company only has come out with animal insulin, purified insulin, your mixed-order, your degludec, and recently Icodec also. Otherwise, the development is persistently happening. We are very pleased with the results of seen in the onward 2 trial. Weekly insulin Icodec is the first insulin to demonstrate the ability to reduce the number of yearly basal insulin injection 365 days instead of 365, 52 insulin per year. And then the smart insulin, glucose responsive insulin. If you inject, whenever the blood sugar goes high, it releases insulin. Whenever the blood sugar comes down, it will not release the insulin. This is otherwise called, it will act as your islet cells. So whenever the blood sugar goes high, your islet cells are secreting, beta cells are secreting insulin. Blood sugar is kept at 140, whatever food you eat. If you don't take food, beta cells will not function. Alpha cells will release the glucose from the glycogen. Similarly, whenever the blood sugar goes up, the insulin will get released. Then whenever the blood sugar comes down, insulin will not get released. Would be injected once daily, could make hypos as history. So patient will not develop hypo. Will help ensure perfect glucose control throughout the given day. So smart insulin implication, long-term best case scenario, 1 injection per day, blood glucose level that stay in zone without hypoglycemia, no more carb count, no more guessing, what does it correct, no more feeling frightened, and much safer and less stressful life. Otherwise called glucose responsive insulin. This is your insulin inhalers. Of course, it got introduced, it had some drawbacks. Your tuberculosis or fibrosis or COPD, the absorption is not that much adequate. So it is not effectively controlling. It is not in clinical use, but persistently the trials are going on for pulmonary insulin. This is Eupora. They were comparing inhaled insulin with Afza used in the Novolog MDI. And oral insulin also going to come. Oramed, ORM, that is pure technology, oral insulin in pipeline. And this delivery platform protects insulin and enhances its absorption, allowing it to reach the bloodstream via the portal vein, thereby enhancing more physiological protein. So this is through portal, it goes and delivers the insulin in the liver. So otherwise physiological action of insulin will be there. This novel insulin pill could end daily injection jab. And man's pancreatic cell implanted in his liver in a life-saving surgery. A major motorbike accident and survived with a severe injury of pancreas. To prevent patient risk of developing diabetes, doctors extracted beta cells from the pancreas and implanted in the liver. The future insulin, inhaled insulin, of course, transdermal patch also going to come in future. So options for initiation of insulin therapy, basal insulin regime, what we are in government hospitals, we are using only your Actrapid, Insulotot, that is NPH, and Mixtod also I think available. And basal insulin, I don't think they have glargine, degludec, levomestrol, basal insulin, long-acting insulin. And once daily premixed insulin regime, co-formulation is Risodac, twice daily premixed insulin regime. Of course, Dr. Pichamani is going to talk on premixed insulin, and basal insulin also Dr. Namachivayam is going to talk. Basal plus is one short-acting, one long-acting. Basal bolus is one long-acting, 2 or 3 short-acting insulin. Summary, newer basal insulin have a flat profile and a far more lesser risk of hypoglycemia. Insulin co-formulation offers the advantage of better glycemic control. Faster insulin and smart insulin can change the dynamic of insulin therapy. Otherwise, over a period of 100 years, there are a lot of changes from crude extract of pancreas to the icodec or smart insulin. Of course, the continuous development will keep on occurring because human being, used to say, greedy animal in the earth is a human. So he wants to update. He wants to live comfortably when compared to other living being on the earth. So for his comfort, he does all these things and modify. So insulin is one among the hormones which got modified over a period of 100 years to this level. So the conclusion, so 1923, your animal insulin, then human insulin, then Lispro insulin, glargine insulin, then Aspart, then degludec, then Fiasp, etc. So the management of diabetes is not simple because while we were undergraduate or even up to my postgraduate or up to year 2000, we had sulfonylurea, metformin, insulin, only these 3 classes of drugs. After that, alpha-glucosidase inhibitors, pioglitazone, gliptins, gliflozins, GLP-1 receptor analogs, 4-5 classes of drugs within these 20 years. And lot of brand names, lot of combinations. So the huge amount of drugs now for practice of diabetes. So treating diabetic patient requires in-depth knowledge about diabetes, benefit and risk of multiple drugs, various combinations, trade names. Because of various combinations, same molecule is getting repeated for the same patient. So without knowing by few of the patient doctors. So, sorry. Various combinations, trade names, their mechanism and duration of action. Patients' affordability also important. If you prescribe costly drug, they may buy for 1 week or 1 month. Then subsequently they may not buy. Lifestyle changes, associated comorbidities like your hypertension, your hypothyroid, lipids, etc., coexisting ailment like your psychiatric ailment, cancer, etc., and complications of diabetes like retinopathy, nephropathy, your neuropathy, etc. We have to keep all those things in the mind before you either prescribe oral drugs or insulin. This is about our 100 years of insulin. Thank you especially for Madam Dean, Madam, and because they have, despite their administrative problems, she is fully listening. Very happy, Madam. And at the end, we can have some discussion. So the youngsters can clarify and some of the senior colleagues also there. So thank you one and all. So the purpose of CME is, I am the Secretary for Alumni Trust. Sekar sir, all our wishes and Annal, etc. So all youngsters in the Chengalpattu Medical College should get recruited yourself as alumni. And future also, you should continue to do this job of association as well as trust job. For that purpose only, we have initiated this House Agents program from 2018. 2019, we had 2 programs. Then because of COVID, we have stopped, Madam. 1 program we had online. So now we have started physically. But this program will go annually, along with our endowment. Thank you. Thank you.
Sir, thank you, sir. Thank you so much for sharing your knowledge regarding and vast experience regarding diabetes mellitus. Thank you, sir. Now we call upon the second speaker, Dr. Pichamani, sir, to share his knowledge about diabetes.
Good afternoon, everybody. I will not take much time. This is going to be more of a clinical topic. And at the outset, I would like to thank Dean Madam and Vice Principal and all the people here, and of course our President and Secretary of Trust. So type 2 diabetes is not a pure endocrine disease. Type 2 diabetes is not a pure endocrine disease. knowledge about type 2 diabetes has to be there for anyone. Be a surgeon, be a physician, be a general practitioner, whomsoever you are. If you don't have a proper knowledge of diabetes, you're going to really fumble upon the patient. There's a high possibility that you commit a lot of errors. So every doctor should know about diabetes. That's the first thing that I want to convey to all the people. Secondly, Professor Samji P. Moses used to say those days, there are diabetologists, diabetic practitioners, clinicians, diabetologists, physician diabetologists, endocrine diabetologists. So there are so many people who are coming across diabetic patients, and nobody can leave it as simple. And but the introduction is, I'm going to talk about type 2 diabetes. It's more of a type C. Paneerselvam sir talked very nicely about the anti-insulin, type 1 diabetes, and so on, newer developments. So we are going to go through a clinical conundrum, wherein exactly what type of patient that we are encountering in our life. It's a garden variety that most of us really encounter in our practice, and many of you would have seen this patient in your clinical practice. So that a type 2 diabetic patient for more than 10 years, hypertension for 3 years, and dyslipidemia 3 years, and the current medications of metformin 1 gram, glimepiride 1 gram, empagliflozin 25 milligram, telmisartan 40, and atorvastatin 40 milligrams. So this is a patient with so many drugs. He's already on 4 drugs. And of course, in spite of that, the fasting sugars and postprandial HbA1c are not under control. And you can see the subsequent follow-up, the postprandial ever rising in nature. So what are we going to do for this man? Are we going to put him on insulin? Is he a candidate? Yes. Almost, you all know, diabetes is a progressive disease. At the time of onset of the disease, almost 50% of the pancreatic beta cells are exhausted. That's why the patient presents with the acute hyperglycemia sometimes. So, that being the case, being a progressive illness, the patients, the beta cells going on getting depleted, insulin is deficient at the time. So, on an average, in India, in Asian countries, we can see when the patient crosses about 10 years of life, diabetic life, most often they settle down, they have to be started on insulin. So, the problem is big. So, in Asia, we are quite different. And in spite of so many newer drugs which have come, the oral drugs, still we find insulin has a lot of space in our practice. So type 2 diabetes is not a pure endocrine disease. Type 2 diabetes is a metabolic syndrome, but in spite of that, insulin deficiency is creeping up a lot. And this is a introductory point about this. So how do you manage this case? So we have to find an ideal drug which can control diabetes well, which should not cause hypoglycemia, and we should have better tolerability. That's a way. So, but what happens in India? The management is a challenge. So we can see the data coming up here. More than 25% of the patients still, they have got very poor glycemic control. Only 25% have good glycemic control. More than 70% do not have a good control. Of course, the 83% of the adults with type 2 diabetes in India have suboptimal PPG control. And most importantly, even though the injections are required, only less than 10% of the patients are started with insulin at the right time. That's a problem. And 38% of total type 2 diabetes patients, they don't adhere, they only adhere to diet. Adherence to diet is a big problem. Lifestyle modification is a big challenge, especially in a country like Asia. And hypoglycemic episodes are quite huge. If one person suffers from a hypoglycemic episode, whether it's mild episode or a major episode, there's a lot of setbacks. I'm going to show you the future slide what is the exact impact of hypoglycemia, what a patient exactly feels about hypoglycemia, and so on. Hypoglycemia, for a doctor, it is simple. For a patient, it's nightmare. If anyone comes across this, it's a problem. So we in Asia, we have a different problem. So the control is not adequate. But be it insulin-naive patients, you can see when compared to the Western population, non-Asians, we have hyperglycemia because we got postprandial hyperglycemia in our country. And because we are starch eaters, we are carbohydrate, we consume a lot of carbohydrates. That being the case, the postprandial excursions are always quite huge. That actually impacts a lot upon the macrovascular diseases, right from myocardial infarction to stroke to all the problems. So uncontrolled glycemia in India demands timely treatment optimization and insulin therapy. You can see all the studies which I've indicated here. The HbA1c levels, DIAP-CARE studies, ACHIEVE study, PRESENT study, IMPROVE study, all the study you can see fasting, postprandial, and HbA1c. All the three are out of control. So we need to optimize the therapy, and insulinization may be an early choice in many occasions. When we start a patient on treatment, we stick with one drug, two drugs, three drugs, four drugs, and the inertia from the doctor is quite huge. Inertia from the patient side is huge. So right from the day one of the disease, we have to counsel a patient about the history of the problem. We have to talk to the patient and patient attenders about how the diabetes is progressive, how it's going to progress in the life, what is the possibility that there's about insulin usage, and there's a possibility of double drug and triple drug combination. Intensification of therapy is needed. All these things need to be counseled to the patient, and this counseling is a must. And more than anything else, we have to counsel about diet. So we in India can see the starch consumption is enormous. So more than 70 to 80% of the energy comes out of carbohydrate and fat in our country. So in the ICDI, IDCA study, it's very clearly documented. The HbA1c control for fasting postprandial, everything was out of control. So the huge participation, you can see how big a trial it was, and it was very clear. More than 83% of the patients had postprandial more than 160, which is not under good control because of the starch. So as I already told you, the OAD inadequacy is there. We keep on increasing the one drug, two drug, three drug, four drugs, and so on. You can see the pie chart. You can see that even after starting the fourth drug, your blood sugars are not under control. And after for adding the fourth drug, you can see the milder bar, which is actually increasing in size, where it is showing that in spite of the fourth drug, the sugars are going up. Whereas once you start the patient on insulin, you can see the bar coming down. That very clearly indicates the insulinization has to happen for the patient at appropriate time. The further delay, every HbA1c of 1% increase is going to really cause complications to the tune of 20 to 30% or 20 to 40%. This has to be conveyed to the patient. So that I used to say in a very easy word, 25 marks for diet, 25 marks for exercise, 25 marks for the monitoring, 25 marks for the medications. The best mark and the last mark is 90 out of 100 for patients. If the patients do not get the 90 out of 100, that's the least pass mark for the patient. The patients are going to suffer a lot. Supposing he gets only 30%, 60 marks out of 100, you can say 40% of the organs are going to get dysfunct over a period of 10 to 15 years. And the complications are going to creep in within 15 years of time. So this should be the way that you explain to the patient. Just in the interest of the students, I'm explaining these things to you. And many doctors who are all here, they know all these things. Of course, let's go to the ideal drug. What is the drug that we're going to choose? Having seen the Asian scenario, having seen the problems that we're facing in India, we now know we have to start on insulin. So we all decided now that we have to start this patient particularly on insulin. So insulin, the insulin should have a mealtime flexibility. The insulin should not cause hypoglycemia. It should be as simple as anything else. And convenience of device should be there. And of course, it should have better quality of life. That's very important. And cost effectiveness, of course, it's there. And more than that, effective glycemic control. And that means fasting, postprandial, and HbA1c all to be normal. Do not accept any patient coming and saying, my random sugar is this. Please accept it. Don't accept it. Don't just say, I'm just seeing once in a way fasting and postprandial. I'm doing SMBG and showing that's the result. No, it has to have HbA1c control and HbA1c, fasting, PP, all the three should be there beside you to say whether the patient is under good control or better control or poor control or average control, whatever it be. So here I'm going to discuss on Idagast, which was nicely elucidated by Professor Pannisalam sir, and we are going to choose that drug as a drug, and we're going to say how this premixed insulin is going to act, and which and why and how we are going to use it, and Idagast. This is a wonderful drug which is very good co-formulation. There's a big difference between the previous premixed insulins and this co-formulation. This co-formulation is very ideal because it mimics physiological insulin very clearly. And it has got no shoulder effect and simplified the insulin regimen, and whereas very clearly the hypoglycemic episodes are very less, and there's a 24 hours coverage when compared to the traditional premixed insulins we have been using. The variability in glycemic control is not much when compared to the premixed insulin that we have been using. The human mixtard, the human insulins, various drugs that are marketed in our country, they got a problem of less than 24 hours good control. The basal coverage is very poor, and of course the glycemic control variability is huge. And of course, there is a need for a shaking of the medicine and so on. The resuspension has to happen, whereas this is not needed for the co-formulation. This was already shown by Dr. Panisalam sir about the ultra-acting degludec, how it's assigned 30 by 40, 30 by 70, and you can see the postprandial aspartate and basal ida component, how it acts and so on. So there is a good this basal control over 24 hours, whereas prandial is being taken by the aspart. You can see the dispersion of this thing, and sorry for the slide. So RSSDA and European Endocrine Society of India practice recommendations 2020 have clearly come out of the thing. That's the first thing is they have suggested ida gasp as a recommendation, the first insulin titre for the insulin titration. So the most important thing, the three points they have come out is avoid using insulin as a threat. Unfortunately, people think it is a threat. Patients think it's the end of the day. Patients think only then my life is gone. The quality of life is gone. So don't do that. Alleviate patient anxiety about insulins. These things can happen only by proper counseling. Spend time with the patient. Unless and otherwise we spend time with the patient, we cannot achieve this. Insulin therapy should be considered in all patients failing to achieve the glycemic targets on more than 3 drugs. Please do not exceed more than 3 drugs. You are going to completely fire the beta cells, which has been already gone off. And so the more the oral drugs, the more the chance of firing the beta cells and so on. So you cannot be going on adding, and don't delay the insulin therapy for the patients. And many studies which has undergone phase 3 and phase 3B with the degludec have clearly shown that this is a wonderful drug and has got least side effects of one. Who are the ideal patients actually who can be started on ida gasp? So the 3 sets of patients, one is uncontrolled on OADs, need for safety, and of course the flexibility at initiation. The most important is many of us delay. See, when the patient is, ideally speaking, when the patient is having fasting and postprandial HbA1c uncontrolled for more than 6 months, that means to say there is a failure. Definitely these are the patients who are going to be started on, who have to be started on insulin. The fasting should fall below 110. Postprandial should fall below 160. HbA1c should be less than 7%, or else all of them need to be started on insulin. So there is no need for that, no delayed. Do not have insulin as a last choice. Do not have insulin as the last drug to be started on insulin. And of course, the second set of patients, uncontrolled diabetes, the flexibility need to be there. So when you are not unable to achieve the flexibility with the fixed drug combinations of premixed insulins, but this degludec has got that flexibility that can do it. And the weight gain is very huge. With some of the patients do say the weight gain is huge. Please beware of that. And in that case, the degludec is a good choice. Of course, hypoglycemia, very, very clear. I have seen patients with a yo-yoing phenomena, with a lot of hyper and hypoglycemic episodes. They settle down with the degludec very nicely. Of course, the drug need to be safe. And of course, in elderly patients, the hypoglycemic episodes are less. So it's a good drug of choice. And of course, when there is a hepatic impairment, when there is a renal impairment, all these conditions, this drug is useful. And because in the fasting state, the patients who are going for a long fastings, we can use this because it's a very smooth acting drug. The degludec is very useful. And erratic meal patterns, it can be there. See, patient profiles again on premix, patients who are already on premix insulins or patients who are already on basal bolus insulins, definitely these drugs, the ida definitely has a more efficiency. Let us see the comparison. Of course, the glargine insulin, everybody knows very well. It's an ideal drug for a beginner. For a patient who has been on higher fasting, the glargine is a drug of choice. We give glargine and patients do well. It's very simple, very easy, and hypoglycemia is very less. Even then, the ida gasp scores over them with the patient fasting and postprandial is more, and HbA1c is more, and significantly brings on the postprandial control when compared to the glargine insulins. So, and the safety aspect also is very good, and comparatively, more than glargine, the performance is ida gasp very, very good. So, I'm just going to skip off these things because more now important. The low risk of hypoglycemia. This is a very, very important area that all of us forget. There are so many episodes of hypoglycemia a patient encounters, even with OHS. Many times they say, sir, by 12:30, I get jitteriness. By 12:30, before I sit for my lunch, I get that mild headache feeling. I get reeling, and many patients do not come and report to you at all. If you are not going to ask, every doctor should ask about the history of hypoglycemia before giving next prescription to the patient. That hypoglycemia can cause so much of damage. Hypoglycemia can kill a patient. Hypoglycemia can precipitate a heart attack. So that being the case, so we should have a drug with least hypoglycemia. You can see the fear of hypoglycemia. I was talking about if a person has encountered hypoglycemia, what all happens? 84.2% experience future episodes. 29.9% experience fear of future episodes as far as mild or moderate. After experience an episode of 16.2%, they skip anti-diabetic medications. 36.7% report decrease in their insulin dose on their own. They don't take the adequate dosage. And 11.7% report missing insulin injections. They will say they are taking, but they are missing the dose. The fear of hypoglycemia definitely kills the patient more than the hypoglycemia, and which is actually going to cause a huge problem. So treatment with Idagasp really resulted in number of non-severe and severe hypoglycemic episodes. That's a wonderful news, and definitely this is going to produce a big change in the patient's life. And visit after visit, you can see the quality of life. And one good thing about insulin is an anabolic hormone. It's an insulin anabolic hormone. Being an anabolic hormone, it gives a sense of euthanasia, really sense of well-being is actually perceived by every patient who takes insulin for the first time. So that being the case, the quality of life is very, very important for diabetes. The patients are going to live for 25 years, 30 years, 40 years with diabetes. Unfortunately, now we are encountering 25, 27, 30 years of diabetic patients. So when these patients, they cross 45, 50, 60 and so on, when they're going to live longer, they should have proper quality, good quality of life. This particular drug is very useful when compared to glargine or any other drug. So the impact on quality and treatment preference, you can see 94.2% manage the day-to-day activities before, after the Idagasp initiation. That improved the quality of life with reduction of number of pricks. Found it comfortable to inject Idagasp in different social situations. That's very important. So reduction of number of injection pricks, flexibility and simplicity of dosing with Idagasp. Once you can change, once in 3 days you can change the dosage of Idagasp, and even it can take once in 5 days to 7 days also, unlike the previous insulins. Switching needs to be individualized. No two persons have the same insulin requirement, and no two persons are same. So it has to be carefully considered according to the clinical scenario and the comorbidities of the patient. So there is no need for any additional consideration. It can be added. As nicely elucidated by sir, there are a lot of pens available. The smart pens have come. It's very, very easy to administer. It's highly painless. So the Idagasp, as I told you, has got lower hypoglycemia, has mealtime flexibility. It's a simple regimen. Convenience of device is there. It's a better quality of life with a cost effectiveness. So it's an ideal drug. So going back to our patient, Mr. Shubha, we start with our clinical scenario. It's a very, very common garden variety patient that we all get, and she is an ideal candidate who can be chosen about this, and which has got a better, which actually fulfills all the need of the particular drug. And I really thank everyone for patient listening, and thanks a lot.
Thank you, sir. Thank you so much for your extraordinary speech, sir. Thank you, sir. Now I request our Associate Professor, Dr. Namachivayam, sir, to give a talk about the newer insulins.
Very good afternoon to respected Dean Madam, Vice Principal Madam, and the office bearers of Chemco Alumni Trust and Association, and dear professors, colleagues, assistant professors, and my dear students. It's indeed a great pleasure for me to be a part of this CME program, And after the two talks by Dr. Pannisalam sir and Pichamani sir, I am going to talk about long-acting insulins. And already, sir, I forgot to mention my teacher, Dr. Shekhar sir. Very good afternoon, sir. So already we are running short of time, and I'll try to make it fast as far as possible. My talk is on long-acting insulin. Long-acting insulins are actually basal insulins. What do we mean by basal insulins? Basal insulins are the insulin which maintain the euglycemia in the fasting state or during the night time. So it suppresses glucose production between meals and overnight. And the requirement is nearly at a constant level. Of the total daily requirement of insulin, nearly 50% of the insulin we need is from the basal insulin. By bolus insulin, we mean it is a prandial insulin. It limits hyperglycemia after a metabolic challenge. So if we consume any meal and there will be a glycemic excursion, and this will be taken care of by our prandial insulin or mealtime insulin, and that is otherwise called the bolus insulin. So for each meal, we require about 10 to 20% of the total daily requirement of our insulin. So this is usual insulin secretion, the first normal. So we have two phases of insulin secretion, phase 1 and phase 2. Phase 1 is immediate response in response to a metabolic load. So that is blunted in type 2 diabetics. I don't have a point as of now. You can see in the type 2, the initial insulin response, phase 1 is blunted. We have only the late phase, that is the phase 2 insulin response is present. So whereas in type 1 diabetic, there is absent insulin secretion. So that's why it's flat. So the basal insulin, again, it is not a constant, continuous insulin secretion. It's secreted in a pulsatile manner. So approximately every 7 minutes or 10 minutes, insulin will be secreted in a pulsatile manner throughout the day. So after a meal, what happens is glucose level increases in the body, and there is an increased burst, that is the response to the food that has been consumed. So that is called the incretin effect. So what is incretin effect? UGs and PGs, what is incretin effect?
PGs can answer. Any PG from any department can answer, because insulin and diabetes is common to all departments, whether you're a surgeon or a physician. All departments can take part in the, what is incremental effect of?
Incretin effect.
One of you get up and answer.
Very good. Due to? So that is very good. So same amount of glucose, if it is given orally, there is an augmented insulin release because of the action of incretin, that is GLP-1 and related hormones, compared to IV insulin glucose, that is incretin effect. So again, I wanted to stress upon that it's again secreted in a pulsatile fashion. So this curve shows again the basal insulin requirement is not a flat or a constant level. So there is a diurnal variation in that also. So there is an increased requirement of a basal insulin in adults from 3 a.m. to 8 a.m. So that is, we commonly come across the phenomenon as a dawn phenomenon. So the first graph, the green color one, shows that dawn phenomenon. So the blood glucose level will be high in the early mornings because of increased basal insulin need. So the another curve on the lower one, the pink one, it tells upon the rebound hyperglycemia in the early morning, secondary to hypoglycemia that usually occurs during the night around 3 a.m. That we call Somayaji phenomenon. So the thing is, basal insulin requirement is not constant, continuous throughout the day. There is the increased basal insulin requirement during the early morning, 3 a.m. to 9 a.m. So we have various armamentarium with us to control diabetes mellitus, as seen in this slide, like insulin, metformin, glycinides, thiazoline, diones, sulfonylureas, all those things, and of which you can see the most potent is the insulin. So it can reduce the HbA1c by 1.5 to 3.5%, where none of the other group of drugs can touch this much reduction in HbA1c. So our regular human insulin, it is a short-acting insulin. It will act for only 6 to 8 hours. For us to maintain euglycemia throughout the day, and especially to take care of the fasting insulin and HbA1c, we need long-acting insulin. Various research have been done in the past, like adding insulin with adrenaline, which causes vasoconstriction, thereby decreasing the insulin absorption, and adding zinc insulin crystallization, and protamine is added. These things were used in the past, and one of the successful combination is the NPH, neutral protamine hedged-on. That is, we are still using nowadays. So this gives us intermediate acting insulin when combined with regular. So other lenti, semi-lenti are not in vogue at present. So after a lot of research, analogs have been found. So these analogs are working for a long time, and the common insulin available as of now is the Glargine U100, that is 100 units in 1 ml of insulin, 1 ml. That is marketed as Lantus. Detimir is marketed as Levemir. Degludec is marketed as Tresiba, and Glargine U300. U300 is, it contains the same Glargine without any molecular modification, but it contains 300 units in 1 ml. So that is marketed as 2GO. So these are the properties of newer insulin. So we classify again into short-acting, ultra-rapid-acting, rapid-acting, intermediate-acting, and long-acting insulin. So the short-acting insulin is a regular human insulin, which has an onset of action with 30 minutes and peaks around 2 hours, and duration of action 6 to 8 hours. Ultra-rapid acting insulin is 5-aspis aspart. It is not modified molecule-wise, but it is when added with niacinamide and arginine as excipients. This makes it to work fast, and it has an onset of action in around 2 to 3 minutes, and its peak action in 60 minutes, and it works for 2 to 4 hours. Rapid-acting insulin, Lispro, aspart, and glulisine, all having action in less than 15 to 20 minutes, and peaks around 1 to 2 hours, and works for 3 to 5 hours. So these are the short-acting insulin, and for basal or long-acting insulin, we have NPH, that is intermediate-acting insulin. It starts acting within 2 hours and peaks around 4 to 6 hours, and it works up to 18 hours. The long-acting insulins are actually analogs, Glargine 100, Glargine 300, Detimir, and Degludec. All this start action in 2 hours without much peak. So most of these have plateau phase, and it works more than 24 hours even. So these are the insulin time curves. So rapid insulin, so it start acting within 30 minutes and peaks around 1 to 2 hours, and it works for 4 to 6 hours. So this is a rapid Lispro, aspart, and glulisine. So this is a regular human insulin which acts within 1 hour, peaks around 2 to 4 hours, and works up to 6 to 8 hours. This is a NPH insulin. So So NPH insulin, it's an intermediate acting insulin. It starts acting within 2 hours and peaks around 4 to 6 hours, and it works up to 14 hours. So this is a long-acting insulin, glargine. It starts acting after 2 hours, and it's almost peakless. So there is a plateau, and it works continuously for more than around 20-24 hours. So this is the action profile of insulin. So basal insulin, they have almost a plateau-like action. So there will not be much hypoglycemia. Bolus insulin, we need inpatient also before taking meals to control the postprandial hyperglycemia. So that is bolus insulin. So in the premix insulin, they mix with 30% short-acting insulin with 70% intermediate acting. Or so that is a premix insulin. So that is a 30-70 ratio is a commonly used. Sometimes we can use 50-50. 50% short-acting and 50% long-acting or intermediate-acting insulin. So that will so we have the easy option of only 2 pricks per day that will take care of the overall glycemic control. So that is a premix insulin. We have co-formulation, IDEC-GASP. What do we mean by premixed insulin and what do we mean by co-formulation? When do we say premixed insulin? So if the same insulin, by combining with NPH, it's made into intermediate acting insulin. That we call premixed insulin. Whereas co-formulation is the insulin are 2 separate insulin, 2 separate molecules. In IDEC-GASP, it's insulin degludec and insulin aspart, so 2 separate insulin combined in a single pen. So that is we call co-formulation. So there we have to say it is co-formulation. So this one slide depicts the actual molecular modification in all the analogs. In glulisine, so we have to know one specific thing regarding insulin analogs. If we modify the amino acid sequence in the B chain from 26 position to 30, we will be altering the properties of insulin by the duration of action, absorption, all these things will be modified. Whereas the receptor binding capacity will not be affected by these changes in B chain from 26 to 30. So we know A chain, B chain, and these linked by 2 disulfide bonds. So insulin glulisine, the 29 position amino acid is replaced by glutamic acid, that is glulisine, and apart from that, in 3rd position B chain, glycine is replaced, lysine replaces aspartic acid. So in Lispro, 28, 29 is interchanged. 28 is proline and 29 is lysine. That is interchanged as 28 lysine and 29 proline. So Lispro. So aspart, the 28 position amino acid proline is replaced by aspart. These are the rapid acting insulin. Coming to our long acting insulin, that is a basal insulin, what happens in glargine is the 2-arginine is introduced at 31 position in the beta chain, apart from glycine in 21 position, that is a glargine. Whereas in detima, the 30th position threonine is knocked off, and the myristic acid, it is a C14 carbon chain, is attached at the 29 position, so to the lysine, that is detima. So in degludec, again the threonine 30th position amino acid knocked off, and C16 fatty acid chain, hexadecanoic acid, is attached at 29 position. So this alters physiological properties and duration of action of these long-acting insulins, and they make it truly once daily insulins. So coming to the individual insulins, glargine. So already we have seen that in the A chain, it's a glycine that is attached at the 20 position, and in the 30th position, we are attaching to arginine. So this is insulin glargine. So it's a clear solution, but it has a acidic pH. So what happens when it is injected in the subcutaneous tissue? It forms microprecipitates. It crystallizes at the physiological pH of 7.4, and from there it is slowly released into the circulation. So apart from that, the substitution of glycine for arginine at 821 further stabilizes insulin glargine hexamers formed in the subcutaneous tissue, thereby slowing the rate of absorption after the injection. So it's indexed in an acidic solution, so it precipitates in the subcutaneous tissue in the physiological pH of 7.4. After that, it slowly dissolutes from insulin hexamers into insulin dimers and monomers. Insulin hexamers cannot enter directly into capillaries, and after forming insulin dimers and monomers, it enters into the capillaries and it starts acting. So there is a prolonged action of this insulin because of the microprecipitate it forms in the subcutaneous tissues. So slow dissolution of insulin hexamers at the injection site results in a relatively constant release with no pronounced peak. So it has an onset of action 2 hours. It's a flat peakless insulin, and it works for 24 hours. So it is to be given subcutaneously only, and it should not be given intravenously. If we give, it can cause very severe sudden hypoglycemia. And again, it should not be mixed with any other insulin because it's in acidic pH, and if we mix with any other insulin, it will cause some definitive problems. So it's available in 10 ml vials, 3 ml pens, and cartridges, which can be used in permanent pens. It's in 100 AU per ml. So regarding the time of administration of glargine, so one study has shown that the administration of glargine in the morning reduces HbA1c in a better level compared to the bedtime insulin. So usually NPH insulin we give as a basal insulin to take care of the fasting plasma glucose. So since it has an intermediate acting insulin and it works for 20-14 hours only, obviously it has to be given at the bedtime only. Whereas insulin glargine, which works for 24 hours or more so, it can be given at any time of the day. So if we give in the morning, it reduces HbA1c by 1.24 compared to the bedtime glargine, which reduces to 0.96, and bedtime NPH, which reduces HbA1c by 0.84. So it's better to give it in the morning. So coming to our next long-acting insulin, basal insulin, Detima. So it's again a soluble derivative of human insulin. What happens here is the threonine at a B chain, 30th position is removed, and 14 chain acid is attached at the B29 position. So this is a myristic acid, C14. So what is the pharmacokinetics of this? So it binds to the albumin in the subcutaneous tissue. From the albumin bound state, it is slowly released into the circulation to the peripheral target tissues. But unlike glargine, it does not form any precipitate. So again, it has an onset of action of 2 hours, and it's almost a flat level. It works for around 20 hours. Coming to our third analog, degludec. So here the A chain is not touched, and the B chain, again the threonine at the 30th position of the B chain is knocked off, and a 16 chain carbon fatty acid is attached. A hexadecandionic acid is attached to the 29th position lysine by a glutamic acid linker. So what happens here? It forms a multi-hexamers. So thereby it causes a slow release of insulin to the circulation. So it has an onset of action in 30 to 90 minutes, and it has no peak in activity, and its action is said to be last longer than 24 hours. So it's injected in the dihexamers state along with the zinc and phenol. After removal of phenol in the subcutaneous tissue, it forms a multihexamers. So the multihexamers are the one which acts as a depot. So it stays there in the subcutaneous tissue, and from there it is slowly released as dimers and monomers into the circulation, and it causes the insulin to have a prolonged action lasting more than 24 hours. So ideally to start with any patient who is on uncontrolled hyperglycemia in type 2 diabetics, we start them on 10 units once daily in the subcutaneously, and again it should not be administered intravenously. So again it should not be used in insulin infusion pumps. Again, another analog of long-acting insulin is glargine U300. So there is no molecular modification compared to glargine here, but in glargine, it is each ml contains 100 units of glargine. Here, it is a concentrated form in which 300 units of glargine in 1 ml. So it alters the physiological properties of glargine in that it has a more prolonged action lasting for more than 24 hours, and said to have less hypoglycemia compared to even glargine, and it is more efficacious. So I'll skip these slides for want of time. So coming to the use in pediatric group, so the basal insulin, NPH insulin, can be used, which we are using already, and insulin glargine is approved for use in 2 years and above. Insulin detimers is approved for use in 2 years and above, whereas degludec, it has been given approval for more than 1 year of age. Again, in patient with chronic kidney disease and CL liver disease, the dose requirement obviously will be decreased when compared to other without this comorbid condition, and insulin requirement may be diminished, and we have to adjust the dose accordingly, but there is no contraindication for use of this long-acting insulin in those individuals. And again, in elderly, all this can be used, but with caution to avoid hypoglycemia. Coming to pregnancy, all NPH insulin we are already using for a long time, and recently the detimer and very recently glargine has been approved for use in pregnancy, and degludec still has not been approved for use in pregnancy. So trials are on. So this is a summary of evolution of basal insulins. So NPH, glargine U100, detimer, glargine U300, that is 2GO, and degludec. So hypoglycemia is common with the NPH insulin because it peaks around 6 to 8 hours, and other insulin hypoglycemia is less severe, but degludec is said to have least hypoglycemic episode overall. So these are the 4 analogs which is currently available for us to use as basal insulin. So for the sake of students here, I would like to touch upon a few points regarding the use of insulin. So we have multiple barriers for us in the treatment of type 2 diabetes. So what are the common side effects? Weight gain, hypoglycemia, and poor adherence, and clinical inertia. So this has to be overcome. And the patient barriers is they fear injection, and they think it's complex. There are many misconceptions about insulin. So it's lethal, it's a punishment, and insulin is having a stigma, and it's ineffective. So these are the patient barriers, and healthcare provider also have some tendency to avoid insulin because of negative attitude and lack of motivation and training barriers, all those things. So risk of hypoglycemia and risk of weight gain are the most common causes of poor adherence to therapy. So bolus insulin, it regulates the blood glucose following a meal. Premixed insulin, because it's a combination of short-acting and intermediate-acting, it regulates both. Basal insulin, it maintains the blood glucose throughout the day. So this is one thing again, maybe probably will be useful for the students here. If the fasting blood sugar is high, so if, what will you do? What insulin dose has to be adjusted? If the fasting blood sugar is high, we have to correct the previous day long-acting insulin. So bedtime insulin, either intermediate or long-acting insulin, that has to be corrected so that we target the desired fasting sugar level. If the post-breakfast sugar is very high, so we have to target the morning short-acting insulin, so or rapid-acting insulin, which you have given. So that only will take care of the post-breakfast blood sugar level. So post-lunch, so if the for pre-lunch it is morning intermediate-acting insulin has to be altered. For post-lunch, we have to either if the patient is on 3 times prandial insulin, we have to correct the lunchtime insulin, or sometimes the morning intermediate insulin has to be reduced. So pre-supper, so that is the night insulin. So it has to be, what has to be corrected here? The morning intermediate acting. So post-supper, it is the night short-acting insulin. So during the night, if there is any hypoglycemia or hyperglycemia, it is a supper time insulin that has to be addressed so that desired euglycemic level is maintained. So again, already we have seen this, the basal insulin requirement will be about 50% of the total daily dose. So 35 to 50% of the total daily dose will be from basal insulin, and breakfast 20 to 25%, lunch 10 to 15%, and dinner 15 to 20%. So with this, I would like to conclude my talk on long-acting insulins, and thank you one and all.
Thank you, sir. Thank you, Namachivayam, sir. Very special thanks to Namachivayam, sir. And by this, we come to the end of the session. Anybody wants to have any discussion or question answers discussion or doubts? PGs? If you don't have any questions, we will ask questions. Any? Yes, ma'am. Yes, ma'am.
கேட்கறதுக்கு முன்னாடி ஒரு சின்ன ரிக்வெஸ்ட் ஃப்ரம் த ஆகஸ்ட் ஆடியன்ஸ். Due to his medical condition, Namachivayam sir has applied for VRS, which has been granted, and it's our duty and honor that we need to send him with a happy note. So madam group la போட்டிருக்கிற மாதிரி Monday வந்து we are planning for a farewell, and we are inviting all of you to honor such a great person. ஒரு standing ovation to Namachivayam sir on our behalf, please. Ever smiling, student friendly, and we are going to miss you a lot, sir. We pray that everything happens in a good note. Sir, உங்களை கூப்பிடுறாங்க.
I request cardiologist sir to please.
We will have a function on that day for people who are. நீங்களாம் வர மாட்டீங்க சார். He came here. Selvan should come here. Come. Both of us, myself, Selvan and Satya, were struggling to administer during COVID period. This man also. Come. Vatmanaban was. So, that time, he was getting into sickness, sir. Sir, such a dependable person, sir. We gave him CMONC ward to, ஒரு டீன் வந்து ஒரு பில்லருக்கு ஒரு வார்டு கொடுக்கணும்னு சொன்னாங்க. I think Namachivaya meant to CMONC block. On an everyday basis, a chief first time went and saw all patients, madam, without knowing that he was sick. Then madam was administering, Jayalakshmi madam has left. But Monday 3 நம்ம நடத்த போறோம் for people who have come here. And that time only he took a leave and we came to know that very dependable, humble, straightforward, honest person, sir. அந்த மாதிரி ஒரு we'll speak about him in volumes later, but people who are not, அது வந்து கோவிட்ல செல்வன் knows சான்ஸே கிடையாது மேடம், அந்த மாதிரி பண்ணாரு. பட் he was sick during that period without so இது ஒரு சான்ஸு. ஸோ அதனால் நம்ம என்டர் பண்ணும்போது சொன்னார் சார், போன தடவை அக்செப்ட் பண்ணிட்டேன், இந்த தடவை கவர்மெண்ட் அக்செப்ட் பண்ணி கொடுத்துட்டாங்கன்னு. ரைட்டு ஏன் சார் போடுங்க சார்.
சார் நம்ம சார் தயவு செய்து திங்கட்கிழமை எங்களோட ஒரு நாள். On behalf of 1987 batch Chemco, souvenir prepared by one and only Padmanabhan sir, அவருக்கு ஒரு பெரிய ஓ போட்டுருங்க. Sir is releasing the first brochure and the souvenir with the details of the event. Humble request from all of us again to please participate and enjoy the show. ஒரே நிமிஷம் பத்து சார்.
ஸோ அனைவருக்கும் எனது காலை வணக்கம். இந்த வாய்ப்பினை நல்கியதற்கு நம்முடைய கல்லூரி முதல்வர்கள் மற்றும் செம்கோ அலுமினி தலைவர்கள் அனைவர்களுக்கும் என்னுடைய வணக்கத்தை தெரிவித்துக் கொள்கிறேன். ஒவ்வொரு வருடமும் டாக்டர் சுரேஷ் அவர்கள் சொன்னது போல் ஆனுவல் செம்கோ மீட் 1997 நாங்கள் அதை தொடர்ந்து செய்து வருகிறோம். நடுவில் இந்த கொரோனா வரும்போது அது கொஞ்சம் இடர்பாடு இருந்தது. இந்த முறை செம்கோ 87 டாக்டர் மேடமும் இந்த பேட்ச் தான், செம்கோ 87 பேட்ச் டாக்டர் அவங்க ஆமாம். அதனால் வந்து மேடம் முதலையாக வந்து மேடம் வரேன்னு சொல்லியிருக்காங்க. அதுக்கு முன்னாடிலாம் வரமாட்டாங்க. இந்த எல்லா அலுமினி அசோசியேஷனில் இந்த அலுமினி அசோசியேஷன் தான் வரேன். அதை தான் நான் முதல்ல சொல்லிட்டேன், ஆர்கனைசிங் அப்போ மேடம் கரெக்டாக நீங்கள் வந்துடணும் அப்படின்னு. ஆமாம் ரைட்டு. ஆனால் அனைவருக்கும் என்னோட அந்த நன்றியை தெரிவித்துக் கொள்கிறேன். இந்த எஸ்ஆர் ஜங்கிள் ரிசார்ட் அண்ட் கோயம்புத்தூர் அணைக்கட்டி அந்த ரிசார்ட்டில் நாங்கள் ஆர்கனைஸ் பண்ணோம். அனைவரும் அமர்ந்து கொள்ளலாம் என்று நினைக்கிறேன். அதை எது சார் வீடியோ இருக்குது, அது என்ன ரெடி பண்ணலையா சார்? அது பரவாயில்ல, நம்ம போட்டுடலாம். இல்லை இது இவங்க மற்றவங்க பேசும்போதுக்குலாம் நம்ம போட்டுடலாம் சார். இல்லை இந்த இப்பொழுது அவுட் கோயிங் சிஆர்ஆர்ஐ பேட்ச், ஸோ நீங்களும் இப்போ அலுமினி அசோசியேஷனில் மெம்பர் ஆக போகிறீங்க. நீங்கள் வந்து இப்போ வாட் வி ஆர் லேக்கிங் இஸ் தி கடந்த ஒரு 7-8 வருடங்களாக இங்கேருந்து படித்து முடித்து சென்ற அனைத்து எம்பிபிஎஸ் மாணவர்களையும் மருத்துவர்களையும் நாங்கள் அதை எப்படியாவது கொஞ்சம் அதிக அளவில் வந்து சேர்ந்து கொண்டு எங்களோட வந்து அந்த அலுமினி மீட்டிங்கில் கலந்து கொள்ள வேண்டும் என்று எங்களுடைய முக்கியமான ஒரு வேண்டுகோள். அனைத்து இப்போ உங்களுடைய பேட்சிலேருந்து ப்ரீவியஸ் பேட்சஸ் எல்லாம் நம்ம அவருடைய ஆஃபீஸ் பேரஸ் ரெப்ரஸன்டேட்டிவ்ஸ் அவங்களெல்லாம் கூப்பிட போகிறோம். இது இல்லாமல் ஒரு சின்ன இன்னொரு எண்ணமும் இருக்குது. காலேஜ் பிஜி ஸ்டூடெண்ட்ஸ் கிட்டத்தட்ட இப்போ 2010 பார்த்தீங்கன்னா பிஜி ஸ்டூடெண்ட்ஸ் அட்மிட் ஆகிட்டாங்க. இப்போ கிட்டத்தட்ட ஒரு வருடத்துக்கு 80 பேர் இப்போ பிஜிஸ் இருக்காங்க. ஆல்மோஸ்ட் இட் பிகம்ஸ் very great number of PGs who have completed. Though the PGs have done their MBBS in some other college, definitely I think all these PGs will have that homely atmosphere இருக்கிற மாதிரி இந்த காலேஜ் வந்து டெஃபினட்டாக ஃபீல் பண்ணுவாங்க. We are going to start a PG Alumni Association during this meet. So I am just encouraging all the PGs also to come and participate, and then we will start a PG Alumni Association. On par association with the UG and PG, we will do the next meetings. In this meeting, we are going to start this PG Alumni Association. 11, 12 and 13, fix your dates. Please don't have any other programs. Kindly come and participate. August 11, 12 and 13. I am welcoming you all for all this event. Thank you.
I wholeheartedly welcome our TNMSC CME observer, Dr. Mohan Kumar, my classmate, TNGD Chengalpattu President and Clinical Establishment Act Committee, District Committee member. Welcome, and please give credit point to the CME. Thank you. Retrospective apply பண்றோம்.
Thank you, sir. Thank you all. And on this occasion, I give my sincere thanks to Dr. Suresh sir, Dr. Ilangovan sir, Dr. R.K. Shegar sir, Dean Madam, and Dr. Pannirselvam sir, Dr. Pichmani sir, Dr. Namachivayam sir, and Dr. Manoharan sir. I think we all had a good sessions regarding insulin. That is 100 years of insulin by Dr. Pannirselvam sir and pre-mixed insulin by Dr. Pichmani sir and long-acting insulin by Dr. Namachivayam sir. So I take it as a great honor to thank everyone who has participated, and the professors, associate professors, PG students, assistant professors and UG students from various departments. So I thank you all for giving an opportunity. I thank the Chemco Alumni Association for doing this function, and I thank Novo Nordisk for helping us they gave the sponsorship. So I thank Novo Nordisk for making this occasion a great success. Thank you all. Food is available for all. We are providing the lunch. Vegetarian is available and non-vegetarian is also available. And I request Dr. Manohar sir to give the vote of thanks.
So in newborn we have only one experience, sir. When I was in Madurai, we had a newborn with diabetes mellitus. So we have managed with insulin, but unfortunately a newborn baby with diabetes mellitus. So the sugar level was some 500 something. So we started on giving insulin for newborn baby, but ultimately the baby expired. Neonatal diabetes mellitus, one baby in Madurai.
Very good afternoon to everybody. I thank all the speakers for their wonderful speech. Sir, regarding just a few discussions to Dr. Pichmani sir. Very good speech of you. So I'm Dr. Sumati, Senior Assistant Professor, Geriatrics. Regarding the discussion about Shubha, the students shouldn't be carrying wrong message. It was a very good, wonderful talk about pre-mixed insulin. So wonderful talk. But I think we want short of time, you had to switch over by. I know you can explain more, but you kept to the time. But just to clarify, I mean, you showed that there are 4 group of drugs used, and then we switch over to insulin. Students shouldn't carry that message. So the idea of using insulin is, or any other OH is, go to the submaximal level of one group, then add a second group, go to the submaximal level of that one, add a third one, and go to the submaximal level of third one, and then fourth one. Next thing is, are there any comorbids? You showed the 172 and 242. So if at all there is a comorbid, such as diabetic foot or a CKD, agreed, we can directly switch over to insulin. I think it's when we discuss scenarios, it is better to show the other comorbids also. And in private practice, yes, we do use insulin for various reasons that we cannot, everything cannot be discussed over here. But I think that should be a thing. In pregnancy, again, the question was whether it will be safe to use. Again, that was covered by Dr. Namachivayam, sir, I think. So your comments on that, and do all insulin, and what is the, insulin doesn't cause any weight gain. So insulin atrophy, yes. Weight gain, can we have a discussion on that? Just 5 to 15 minutes. Thank you, sir.
Actually, you raised a good point in this. See, whenever you are going to start a treatment for type 2 diabetic patients, the type 2 diabetic patients are going to come in the spectrum. The disease is a spectrum, actually. They come with one presentation for you, and at what time the patient presents to you. So this patient, I just given a glimpse of a few points. We can add on to any number of points in this. So the idea of this particular session is to just sensitize about hypoglycemia, sensitize about the appropriateness of insulin initiation and intensification. It's not just before, I have not discussed the case entirely. It's not an entire case discussion. Entire case discussion will be quite different. And that time we have to discuss each and every component of it, whether the patient had a EGFR, how much of EGFR was there, and whether the drugs were optimized here or not. Have we given the correct dosage? Even theoretically speaking, even clinically, we can increase the dosage of metformin up to 2,500 mg. So that was not there. So this is just a scenario, a garden variety of patient that enters into a OP, and how much of inertia the physician has and the doctors have regarding the insulin initiation and intensification. And switching over from drugs to insulin, we should not delay. This is an example of delaying. That delay has to be avoided. So the patient has failed to respond long time back, but we have initiated later. So it's only a sensitization program where we are just trying to insist upon that. But definitely, as you rightly said, the comorbidities are there, the age is there, and along with that, the other factors are there. And of course, regarding the weight gain aspect, definitely insulin weight gain is there, no doubt about it. And it all depends. Now, say, for the sake of discussion, in type 2 diabetic patient, leave alone this patient, when we want to treat with presently we got SGLT2 inhibitors, we got gliptins nowadays. So definitely we can start with those patients. So next to metformin is not just the sulfonylurea. Next to metformin nowadays we start on SGLT2 inhibitors, we start on gliptins, and definitely they do very well, no doubt about it. So we can actually really control the diabetes sugars with the fasting, postprandial HbA1c. Smooth control is there with all these drugs, which are nowadays available at a lesser cost also. That's good. So that is the usual thing that we start. What is after metformin? Lifestyle modifications being the pillar, we cannot forget about it. And for non-response to a medication, non-response to therapy, does not ideally mean the patients are doing well. So most of the time, you can say 70% of the time, they are not having proper good lifestyle modification, which many clinicians, especially the beginners, should understand that we should sit with the patient and talk to them. Many times, being young diabetic patients, they don't have time for anything. Exercise they don't do, they don't have proper diet control, they are actually roaming around. Sometimes they're executives, and sometimes they're still doing only sitting job. So there are so many factors. The stress is very high. There are very many factors why patients do not control very well. So the blood sugar control is not just giving medicine and treating the medicines. We are not drug sellers. We are not medication promoters. We are there to take care of the patient as a whole. There are so many things to be discussed when you start treating the patient. So this is only a just scenario where how we have to really intensify and initiate without harming the patient. Thank you.
We have 2 teaser videos and one inviting song from our batchmate Meenakshi. Another 5 minutes more. First and then the teaser video. This song was sung by our Shagar sir. Please give a clap to him. Dr. Shagar sir.
வாங்க நீங்கள் கரங்கள் நீட்டுங்கண்ணா செங்கை படிச்சவங்க சங்கம வீட்டுங்கண்ணா ஏ ஆகஸ்ட் 11 தேதிய மனசிலவை நீ ஆட கட்டி ஸ்பாட்டில தான் நேரில வந்து செய்ய அடனேக்கா வந்து சோகா செய்ய பொன்னாக கூடுவோம் திக்கையே திக்கணா தேதிய மனசுல ஏத்திக்கணா ராத்திரி 2 இருக்குங்கண்ணா சொர்க்கத்தை மறுபடி பார்க்கடலாம் வாங்கண்ணா நீங்களும் இது சிங்கார வீட்டுங்கண்ணா செங்கையில் படிச்சவங்க சங்கம வீட்டுங்கண்ணா
அடுத்த வீடியோ கடைசியில் இல்லை அடுத்த வீடியோ ஒரு வீடியோ இருக்குல்ல அதாவது போடுங்க. அவ பாடின பாட்டு தான் இதில் வருது, வீடியோட வருது. மீனாட்சி எங்கள் பேட்ச் தான். போயிட்டு வந்தது போதும் சார் சார் தேங்க்யூ வெரி மச் சார். ஐ எம் requesting all please attend and I am kind request, today is my elder daughter's birthday. Please give her all your hearty birthday wishes. Thank you. Her name is P. Ashwati Preeta. Thank you sir. Thank you. Sir. இருக்கு சார். வேற சார் போதும் சார். போட மாட்டேன்றாங்க. போடுங்க சார். கண்ணா இதுப்பா போடு. வந்த பாட்டு வேணாம் பாட்டு
There are 50,000 followers for her in Instagram, and some of them are celebrities are following her on Instagram, and she has reached a status of very high required. And she wanted to be a model from age 6. She age 6 la model da avan sonna she has become a model. Enga photo podu ஒரே அந்த ஜெய்சன் டெக்ஸ்டைல்ஸ் போட்டோ மட்டும் இருக்கு. அது மட்டும் போடு. அது போட்றேன். பரவாயில்ல ஓப்பன் ஆகல. ரைட். So for those who do not know my daughter, that white dress, this is my daughter Ashwati Preeta, right? So this poster is in Jayasundran Textiles, Tambaram, outside. It has been displayed in the. Right. Thank you very much. Thank you, sir.
So thank you all.